mechanically, chemically, and that is also applicable to muscles, skeletal muscle. And in the anatomy department, you have seen a good number of skeletal muscles. Upper extremity, lower extremity, there are the muscles. তোমাদের এখন কি চলছে এখন আপার এক্সট্রিমিটি না লোয়ার এক্সট্রিমিটি লোয়ার এক্সট্রিমিটি চলছে হ্যাঁ কোয়াড্রিসেপস ফেমোরিস মাসেল ডিসেকশন তোমাদের হয়েছে এখনো হয়নি শুরু হয়নি ডিসেকশন হয়নি ফিমোরাল ট্রায়াঙ্গেল হয়েছে ফিমোরাল ট্রায়াঙ্গেল muscles, skeletal muscle. Essential for life. It is an excitable tissue and it is related to skeleton mainly. Skeleton. Movement is possible with this and the skeletal muscle, if you consider and is the bulk of the muscle. These are the tendons and it is composed of muscle fascicles, muscle fascicles, muscle fascicles. Muscle fascicles are formed of muscle fibers, muscle fibers, muscle fibers. Whole skeletal muscle is surrounded by a connective tissue, epimysium, and there are fascicles composed of muscle fibers, and they are surrounded by perimysium. And individual muscle cells surrounded by another thin connective tissue, endomysium. It is also related, similar to that of the peripheral nerves. Now this muscle fascicle composed of muscle fibers. Muscle fibers are really cells. They are elongated in structure and they are multinucleated. They are multinucleated and they have striations. Like microscopy or electron microscopy, and they show the striations, muscle fibers of different dimension, 20 to 100 μm, 20 to 100 μm, multinucleated, and they have striations like that. Cardiac muscle also have striations, but they branch and they interdigitate with others. But here it is not so. And these are called alternate dark and light band. Light and dark bands, alternate. So they are called striated muscle, striations. And they are voluntary muscle. We can control their movement and they are essential for our existence because respiratory muscles are the striated muscles. If respiration stops for a minute or so, and these muscle cells, they begin and end at the tendons and their length vary according to the length of the whole muscle. It may be few millimeter in some cases, many centimeter in others. and they are parallel to each other. They have no anatomy, there is no gap junctions between them, and they can contract individually or in group. Suppose if there is another muscle fibers, and they have these striations. In this way. So, and they are in the register. So, under the light microscope or electron microscope, you can see these striations, light and dark band. They are also called isotropic and anisotropic bands. Due to difference in the refractive indexes, and it is due to some arrangement of filaments, it is possible. And it is due to the behavior of the polarized light during this passing. That is called isotropic or light band, and anisotropic is the dark band. Capital letter A and I, you can easily remember. Alternate bands are there. Clear? Now the muscle fibers are formed of innumerable number of myofibril. They are also elongated structure, and it is a myofibril, and it is myofibril. After this myofibril, it can be displayed by the light microscope, but for higher magnification is required to explore the other elements. And this myofibril is formed of filaments, and filaments are composed of proteins, cytoskeletal elements in really, and they have the property of contraction. And this myofibril is consist of these filaments. In the register and not overlapping, and for this reason the individual muscle or muscle fiber or the myofibrils, they all show this bending pattern, and they are in register. If they would have been overlapping, then this type of features cannot be, bending pattern cannot be seen. And this is the part of the myofibril, and they are the filaments, thick filaments, and this is the thin filament. And if you magnify this, then you have this type of features. It is a thick filament, and there is the thin filament. Interdigitation. In this way they are disposed. Yeah. And it is called A band, anisotropic band, and it is the I band. Totally, this is the I band total. This is I band. This is half I band. Half total is, there is the I band, isotropic band. So it is in the resting or in this position. This is the I band. And in between there is a deep line, it is called Z line. jet line. And within this part, this is the dark band, but at the center there is relatively lighter region. It is called edge band. Edge band. Relatively lighter. Yeah. And at the middle of this A band, there is this M line. There is some dilatation, and this is the M line. M line. It is the M line. M line. Yeah. M line. This is this bending pattern, this is the bending pattern, and it continues. And these filaments are formed of proteins. Thick filament, suppose its dimension is 60 nanometer or so, and thin filament 6 to 7 nanometer or so. Their diameter. 16 in case of myosin, and it is called myosin filament also. And actin and myosin, they are cytoskeletal protein you are familiar with. Molecular motors, part of and there are molecular motors by means of which the cytoskeletal elements move. Similarly, it is a cell, nothing but the cell, have different length also. Yeah. And the contraction is taking place in this case. In case of neuron, it is only the excitation that is produced. But here the cells has the power to contract also. The language of the neurons is the action potential. Generation of action potential. Clear? Generation. And the liberation of neurotransmitter from its end, it is the function of the neurons. They cannot contract. But in their case, there is generation of action potential. At the same time, there are contraction. Suppose it is the elongated muscle cell. If you consider a muscle cell, it is the resting condition, and it is stimulated by the nerve. Whenever there is action potential arrives it, then there is generation of action potential. And in response to this, there is the contraction of the muscle. There is the contraction of the muscle. Contraction of the muscle. That is, the volume remains same, but the length diminishes. It was the initial length, and it is the final length. And it is possible with the contractile elements. So actin and myosin, they are present in this regular array in this case. Then we have to know how they are composed of. This filament is composed of proteins. They are called myosin 2. Myosin 2. Within the cells, all the living cells, they have myosin. This is myosin 1. And here it is myosin 2. Myosin 2. It is a heterohexamer. Hundreds of myosin molecules come together to form this thick filament. And their structure you will find in every good book in this. The N-terminal end, and it is C-terminal end. This is the N-terminal end. And this length is 134 nanometer or so, whatever it may be. And there are two on the head, light chains. 1, 2, 3, 4 light chains. And these are the heavy chains. And total molecular weight 460,000. Now you can confirm these figures in your good text. বুঝতে পেরেছো তো? There may be mistake, whatever it may be. Now their structure is now in this way. These are the heavy chains, and this is the light chains, 1, 2, 3, 4, heterohexamer. And they are named in different way. One is phosphorelatable light chain, another is the alkali light chain in some text. In other text, one is the regulatory chain or phosphorelatable chain. Commonly, textbook of Ganongs, they describe as phosphorelatable chain and alkali light chain. They are in this way, myosin 2 molecule. Myosin 2. Myosin 2. And hundreds of these come together to produce this thick filament. তাহলে কিরকম ভাবে সেটা তৈরি হয়? তাহলে they are aggregated in this way. These are the heads. In this way they are disposed. Hundreds come together. ঝাঁটা যেমন তৈরি করে, ঝাঁটার কাঠি যেমন এপাশে ওপাশে লাগিয়ে এরকম ভাবে তৈরি করে, সেরকম ভাবে তৈরি আছে। So at the central part, and these are the heads. These are the head part of this myosin 2 molecules. At the very center, they are not present, and they form pseudo H zone. Around the M line, around the M line, there are some part that is called pseudo H zone. Because these heads are absent here at the very center of this M line and pseudo H zone. M line and pseudo H zone. Hundreds. 200, 300, they come together to produce this thick filament. Thick filament is that it indicates this dark band. This dark band. And it is and in between them in the relaxed state, this is the I bands formed by actin filament. And the head part that contains this system by means of which actually there is the sliding movement occurs between the thin filament and the thick filament. Length of the thick filament remains constant during complete contraction. Thin filaments also remains the same dimension, but the H band, they disappear in complete contraction. And similarly, I band disappear during complete contraction. And there is interdigitation, so they come together. They overlap each other. Actin filament, how this actin filament is produced? It is produced by this. It is a polymer of G-actin molecules. Polymer of G-actin molecules. They are produced as polymers. G-actin is a globular actin, and it unites with one another. In this array. পুতির মতো মারা হয়। পুতির যারা পুতির কাজ জানে তো তোমাদের মধ্যে কেউ নিশ্চয়ই পুতির কাজ করেছে। পুঁতি একটা সুতো দিয়ে তুমি তৈরি করলে, আর একটা তৈরি করলে, এবার ওটা জড়িয়ে দিলে, ওইটা যা তৈরি হবে সেটাই একই জিনিস। ডাবল হেলিক্যাল স্ট্রাকচার, ডাবল হেলিক্যাল স্ট্রাকচার। দুটো সুতো নিলে, একটা রেড একটা হোয়াইট নিয়ে দুটো এন্ড যদি করে দাও, পাকিয়ে দাও, তাহলে পরে যা তৈরি হবে সেইভাবে তৈরি। নেচার তো একইভাবে তৈরি করছে, সবভাবে এইভাবে তৈরি হচ্ছে। এটা হচ্ছে জি অ্যাক্টিভ। Individual molecule is G active, global active, and when it is formed, then it becomes insoluble, and it forms F active. Total is the F active. 300 to 400 G active molecules come together, and they form this type of polymer. And so they are groups. এবং দুটো সুতো যদি এরকমভাবে জড়িয়ে দেওয়া যায়, তাহলে কি হবে, গ্রুপটা থাকবে দুটো সাইডের থাকে, দুটো গ্রুপ পাওয়া যাবে। বাড়িতে পরীক্ষা করে দেখতে পারো, দুটো দড়ি নিয়ে যদি দেখবে দু সাইডে যখন জড়িয়ে দেবে তখন দুটো গ্রুপ তৈরি হবে। অ্যান্ড দিস গ্রুপস আর অকুপাইড বাই ট্রোপোমায়োসিন মলিকুলস। বুঝতে পারছি? যে পুঁতির কাজ করেছে সে খুব সহজেই বুঝতে পারবে যে এটা কীভাবে তৈরি হচ্ছে। পুঁতি দিয়ে তো সব রকম তৈরি হচ্ছে, ব্যাগ ট্যাগ সবই রকম পাওয়া যাচ্ছে, নানা রকমের জিনিস পুঁতি দিয়ে তৈরি হয় সেরকম। তাহলে দুটো করে গ্রুপ থাকবে, দুটো গ্রুপের মধ্যে থাকছে ট্রোপোমায়োসিন মলিকুলস। সাপোজ দে আর ইন দিস ওয়ে, formed in between 40 to 60 tropomyosin molecules, they come together. Tropomyosin molecules, suppose it is alpha and it is beta, but when at a particular group they are and beta of liberty and alpha of liberty. In this way they are disposed. বুঝতে পারছেন তো? ওটা তৈরি করার পরে সেখানে আবার নেচার ওরকমভাবে করে দিয়েছে, এইরকমভাবে তার চেইনগুলো রয়েছে। ট্রোপোমায়োসিন মলিকুলস, 70,000 molecular weight tropomyosin. They are disposed in this way. And over the tropomyosin at regular distances are the troponin molecules formed of 3 parts: troponin I, troponin T, and troponin C. Clear? At distances. Suppose 38.5 nanometer. This is not every book, but I can remember a common biochemistry book. And this part is discussed very well also in biochemistry tests. At distances, there are the troponin molecules. Suppose in their position, there is this troponin TCI. Molecular weight between 18,000 to 35,000. They're variable. There is this 3. There is the globular part at distances. And troponin T means it unites with the tropomyosin molecule. Troponin T unites with the tropomyosin molecule, and it also binds with troponin C and troponin I. Troponin I binds with the actin molecule. Troponin T unites with tropomyosin. The basic concept, suppose it is the troponin T and it is the C and it is the I, and T unites with the tropomyosin, and troponin I unites with the actin monomer. It is the actin. In the relaxed condition, it is tightly bound. Yeah. Tightly bound. and troponin C unites with calcium ion. 4 calcium ion it can bind, calcium ion. And when it binds with calcium ion, then there is some conformational change. That is, the binding of troponin I with the actin is loosened. And tropomyosin has some movement, lateral movement, and it exposes some part over which myosin head can unite. Suppose in this condition, it is obscuring some part of the actin that is obscured. But when calcium binds, then there is lateral movement and it will expose some site of the actin over which the myosin head can bind. And when it binds, then there is reaction of ATP breakdown. ATP is gives rise to ADP plus PI plus energy. In the resting condition, it remains in this state. But when it binds with the actin, then there is some explosive type of action. Then the reaction is increased in that sense, that is, they are liberated. ADP and PI is liberated along with the energy, and that is responsible for the movement of the head of the myosin filament. Now if you consider this myosin filament, now in this pattern if you consider, it is the myosin head, and there is relative movement, and it has actin binding site, and this part is the actin binding site, and some nanometer distance away, that is the ATP binding site. And when ATP enters it, and it converted into ADP, adenosine diphosphate plus inorganic phosphate, and the energy is conserved, and it is in that form. But when it binds with the actin molecules, then there is liberation of this ADP and PI, and energy is used, and there is movement of this part. And actin filament will move in this way. 45 degree or movement in this way. And that is responsible for the contraction of the whole muscles. There are also other cytoskeletal elements, and then this polarity is in the reverse direction, in the opposite direction, and they all bring these filaments close together. So there is, whenever it is fully contracted, then there is obliteration of the I band, there is obliteration of the H band, and then the sarcomere will be short. Sarcomere between the Z lines, the space between the Z lines are called sarcomere. In the completely relaxed condition, it is 2300 nanometer or 2.3 μm. And when fully contracted, that is the A band, when it is overlapping, then the Z line comes together and it becomes 1800 nm or 1.8. And there is no AJ band and this I band. And it was very early they recognized this. And they thought that this is the basic mechanism by which the contraction is coming. And what percentage of shortening, they differ in different texts. And you read different texts or same text, whatever it may be, the basic concept is required. And in this way, there is movement. And to know this, we have to go through some part of the histology. And from this, you have understood that calcium ion is required. And how calcium ion is entering into the cell, or it is available within the cell, you have to know. So some part of histology. there is sarcoplasmic reticulum. Sarcoplasmic reticulum. Reticulum is a specialized endoplasmic reticulum of the muscle cell. Reticulum. And this reticulum has two parts. One is terminal part, there is called terminal cisterns. And there are other parts, there is called L tubules or longitudinal tubules. Longitudinal tubules. And they are surrounding these L tubules or reticulum, they are surrounding these myofibrils. Surrounding these myofibrils. And they contain, cytoplasm contains good number of nuclei. And they contain glycogen and creatine phosphate and other elements, cytoskeletal elements. Now this, for this purpose, when you consider a cell, then there are the sarcoplasmic reticulum, they are surrounding this myofibril, and at the AI junction, in the relaxed condition, if you consider with a different color, at the AI junction, in case of a skeletal muscle relaxed condition, and then you will find that there are some dilatation in this. These are terminal cisterns of endoplasmic reticulum. In fact, they are like the reticulum, they are surrounding these filaments of the myofibril, and they harbor this calcium ion stored in this with calsequestrin protein. Calsequestrin protein, they have harbor numerous calcium ions, and in between the two there is some space, and that space is occupied by this transverse tubule or T tubules. And they are connecting with the extracellular fluid coming from the sarcolemma. And it is required for the excitation contraction coupling. Excitation contraction coupling. You are familiar with the term? In case of excitable tissue, there is only excitation. But whenever there is contraction, there must be some contractile element. Excitation followed by contraction. Like lightning and thunder. আমরা প্রথমে আগে বিদ্যুৎ দেখি, তারপরেই মেঘের গর্জন শোনা যায়, তাই না? মানুষের মধ্যে প্রথমে ঝগড়াঝাটি হয়, হ্যাঁ, তারপরে মারামারি হয়, হ্যাঁ। এখন ঝগড়াঝাটিটা কাদের মধ্যে হয়? তাদের মাসেল পাওয়ারটা কম, কন্ট্রাকশন থাকে না, পরস্পরকে গালিগালাজ করে, সেটা আমরা টিভিতে দেখে এক পক্ষ নিয়ে বেশ একটু আনন্দ অনুভব করি। তা এখন সেই ক্ষেত্রে যেখানে কন্ট্রাকশন, মারামারি যেখানে হবে, তার মানে তার মাসেল। সেদিন দেখেছে স্কুলে একজন হেডমাস্টারকে একজন বলবান লোক ঘুষি মারছে। আই এনজয়েড দি আইটেম, খুব সুন্দর। সে কোনো একটা অন্যায়ের প্রতিবাদ করেছিল, করা উচিত হয়নি, হ্যাঁ, সে কেন প্রতিবাদ করতে গেল? কাজে যেটা হয়ে যাচ্ছে মেনে নেওয়া উচিত ছিল, করেনি বলেই মারটা খেলো, হ্যাঁ। কিন্তু আমরা যারা দেখলাম তারা বললাম যে না, আমার পয়সা সার্থক, আমি এটা একটা দৃষ্টিনন্দন জিনিস দেখলাম। সে বলবান লোক মেরে যাচ্ছে। সেই রকম এক্সাইটেশন কন্ট্রাকশন কাপলিং। Excitation means action potential followed by contraction, and this excitation is required to make calcium available to the contractile elements. Clear? Contractile elements, myosin and actin. Myosin and actin are the true contractile element by cytoskeleton, and relaxing element are the tropomyosin and troponin. In the relaxed condition, we discussed that it will obscure the site where the myosin head can bind. So they are the relaxing proteins. In that case. So in the if the stations are asked in the examination, the actin filament is composed of F-actin, formed of polymerization of the G-actin, and it is group, that is the tropomyosin at regular distances, and at intervals of 38.5 nanometers. So they are the troponin components. And this actin filament that is produced, that is also a pitch. And they are in regular array. 35.5 nanometer is the wavelength of the thin filament. Everything not given in every text, and that is not much required. It is not essential to remember everything in details. It is not possible and it is not required. But when you go to the books, initially you can remember everything. But gradually you forget, only you can remain the basic things, what is occurring. Now, these are this sarcoplasmic reticulum. It contains the terminal part, it is called terminal cistern. It is relatively dilated part. It is well developed in skeletal muscle. And between these two, there is the T-tubule or transverse tubule. And it is communicated with the extracellular fluid. And they together, they form the triad. And the T-tubule is required to bring the action potential within this structure, within the cytosol. Action potential. Yeah. If this, in case of smooth muscle, in some cases, multi-unit smooth muscle, the cells are very short in length. And there is no requirement of T-tubules. Whenever it is depolarized, then calcium do enter. And that is sufficient for the contraction. There must be change in the membrane potential, but action potential is not essential in that sense. If the cell volume is small, length is very low, then action potential is not required. Some depolarization is required so that this calcium ion can enter. In some multi-unit smooth muscle, then there is no requirement of the T-tubule. But it is the elongated structure, many centimeters may be the dimension. So at a single time, there must be spread all through this. So the the cell can contract as a whole within a short time. Contraction is different parts at different times is not warranted. It requires to contract the cell at the same time. And for this purpose, the nature has devised this mechanism to bring the membrane potential within this. And whenever there is action potential, and then there is liberation of calcium from these terminal cisterns. Entry from the outside is not required. Entry from outside is not required. Whenever it is, the action potential is reaches this, then there is sufficient amount of calcium is liberated. And that is responsible for contraction. External calcium is not required. Skeletal muscle, they contract quickly. It is every survival value. So it is not dependent as such on the extracellular calcium and concentration. On the other hand, cardiac muscle, the T-tubule is much wider. T-tubule is much wider. And this type of regular triad may not be present. But this type of structure is also present in cardiac muscle. And entry of extracellular calcium through this T-tubule into the cell is essential in case of cardiac muscle. In the practicals, amphibian practicals also, if the cardiac muscle is placed in a fluid that have no calcium ion, then it will fail to contract after some time, but is not in the skeletal muscle. In nerve muscle preparation, it is independent of extracellular calcium ion. When you stimulate the nerve, it will contract, because huge amount of calcium is available within the cell, and that is the requirement. And this calcium ion, when it is liberated, and it will unite with the troponin C moiety. And when it unites with this, then this troponin I binding with the actin, with the troponin is loosened. loosened, and there is relative lateral motion of the tropomyosin. And with this, there is the exposure of the sides. And when there is the movement, lateral movement, then the site is exposed. And myosin head can bind with it. And when there is increased intensification of the myosin ATPase activity. And then there is the contraction. Understanding that there is the movement of this, is called power stroke. There is movement from this position to this position, called the power stroke. And with single action potential, it has been seen that there is the movement is 10 nanometer or so. And a good number, they undergo this type of contraction, this type of movement. And they are rapidly repeated. Whenever there is brisk contraction, it is 5 times per second, this type of movement going on. And in this way, there is the sliding of the actin filaments within the thick filaments, myosin filaments, and there is a shortening of the muscle and force generation. Yeah. And so excitation contraction coupling is important for the examination. Frequently appears in the examination. Excitation contraction coupling. Suppose it depends upon how you will describe, it will depend upon the marks. If it is 10 marks, then you have to go into the details of this to some extent. But if it is 5 marks only, a flow chart may be sufficient. So what occurs? Normally skeletal muscle does not contract without the action potential of its supplying nerve. Then, so whenever there is excitation contraction coupling, you will find this in your text. From the nerve, lower motor neuron, action potential is coming at the neuromuscular junction. And from the nerve, there is the liberation of acetylcholine. Acetylcholine will be released, and that will combine with that of the nicotinic receptor, muscle type of receptor, nicotinic receptor of the muscle, neuromuscular junction. And in that case, it is the folded position. It is the muscle cells. In that case, there is the folded position. And it is negotiated by this terminal part of the neuron. And then it contains the vesicles. They are concentrated in this part. Typically more at this part, apical part. This got active zones, acetylcholine containing vesicle, clear vesicles. And whenever this action potential is coming, then there is entry of calcium ion through this is the voltage gated calcium channels. And there is exocytosis of this acetylcholine containing vesicles, and acetylcholine is available. It unites with these receptors, and it diffuses into this receptor, and it is the ligand-gated receptors, and initially there is formation of the end plate potential, and it regularly reaches the action potential, and action potential will propagate on either side. More than the requirement is always available. Whenever the action potential is arriving at the neuromuscular junction, Initially, there is end plate potential. It is the sub-threshold potential in that sense. And when it reaches a particular value, then there is generation of the action potential of the axolemma. And normally more than this requirement is liberated everywhere. So regularly, whenever there is action potential, then there is muscle contraction physiologically. বোঝা গেল? এর বুঝতে পেরেছো? In the nervous system, in the central nervous system, there is a neuron and there are good number of the synapses. And whenever the individual synapses consider, in that case, there may be depolarization or in some cases hyperpolarization, and there is every chance of integration. But in this case, whenever there is action potential, the muscle cell supplied by that branch, normally it will always reach the action potential is contracts. মানে আমরা যে এটা যে আমরা চিন্তা করে কোনো একটা কাজ করছি চিন্তাটা যখন হচ্ছে তার মধ্যে পজিটিভ নেগেটিভ হচ্ছে, এখন চিন্তাটা যখন সঠিক হয়ে গেল যে এটা করা যুক্তিযুক্ত, সেটার ভবিষ্যতে ভালো মন্দ কী হবে সেটা বিচার করে না করার উপরে সেটা তখন নির্ভর করছে না। বুঝতে পারছো তো? যেমন আমি একটা ঢিল ছুড়লাম, আমি একটা লোককে ঢিল ছুড়লাম, সেই লোকটার সঙ্গে হতে পারে ঝগড়া হয়েছে, লোকটা সামনে দিয়ে যাচ্ছে, আমি ঢিল ছুড়লাম, তখন আমার বিবেক বুদ্ধি আমার লোভ হয়ে গেল। কিন্তু আমি যখন অ্যাকশন পরিচালনা হয়ে গেল, কাজটা হয়ে গেল, কিন্তু আমার ধারণা ছিল না কোনো সিসিটিভিতে আমাকে ধরা পড়লাম। বুঝতে পেরেছো তো? তার মানে কি ভাবিয়া করিও কাজ, করিয়া ভাবিও না। সেই জন্যই সিস্টেমটাও এরকমভাবে আমাদের তৈরি হয়ে রয়েছে। ফিজিওলজি ইনক্লুডস the good people like you or bad people like me, but you have to know the physiology. That is, whenever there is action potential, there is initially there generation of the end plate potential. Normally it always reaches this firing level and there is generation of action potential and it will propagate. And this action potential will enter by means of these T tubules. And the cell as a whole can contract quickly. And when this calcium ion binds with one, there is this seed, troponin C moiety, then 7 binding site of the myosin head is exposed, 7 myosin heads, and they undergo contraction. In this way, force can be generated. And in some text, it has been possible to know the force generated at a single cross bridge, and it is called cross bridge also. Myosin head binding, it is this cross bridge, and force that has been calculated. 1 piconewton or so, this value. Textbook of boron, they explain in this way. It is not always possible to go into everything details, and it is different subjects, time is short, so it is not possible to go through all the books at this level. But I should mention, those who are interested going to library, you can then, that it is possible to measure the force generated at a single cross bridge. Yeah. Now, what occurs in this case? Then there is the action potential. Initially, there is the end plate potential, and it can be demonstrated by means of, if the receptor is treated with curare, then the end plate potential can be demonstrated. In the neuromuscular junction, there are innumerable numbers of receptors. Suppose in a good text, there is written, suppose it is 15 to 40 million receptors. And 60 vesicles are liberated by action potential. 60 vesicles. And each contain 10,000, that is these molecules. And it is 10 times that is the requirement. If only 6 vesicles are liberated, it is sufficient. But the nature is cautious in this case. So sufficient amount is liberated. It is the more than 10 times of the requirement. So end-plate potential always reaches the action potential. But if this receptor is to some extent poisoned by Q ray, and in that case, end-plate potential can be demonstrated because they are occupied. So in that case, there is depolarizing potential or the localized potential, end-plate potential can be demonstrated. And there will be every chance of temporal summation, because in a single muscle cell, single skeletal muscle cell has only a single nerve ending, has a single action branch, that is terminal buttons. So single neuromuscular junction. So there is no scope of spatial summation, but temporal summation can be demonstrated in that case, in cuiratus muscle. That is the rapidly repeated stimulation can bring the cuiratus muscle into action potential. Yeah. Now this end-plate potential, it always reaches the action potential, and it will propagate. And then this calcium ion will be liberated. Calcium ion will be liberated from this terminal systems. And here there is dihydropyridine receptors. Dihydropyridine receptors in the T tubules and ryanodine receptor in the sarcoplasmic reticulum. Dihydropyridine receptors, it is a calcium channel. So calcium can enter, but in case of skeletal muscle, it is not required. It only triggers the release. And ryanodine receptor, that is by the endoplasmic reticulum, it is a ligand-gated channel. And somehow it is opened by this action potential. So dihydropyridine receptor, structure of pyridine, you can find your biochemistry text. Dihydropyridine and ryanodine receptors, it is a calcium channel, ligand-gated calcium channel in the sarcoplasmic reticulum, and calcium will come out. In the resting condition, the calcium ion concentration within the cytosol is 10 to the power minus 7 to 10 to the power minus 8 mole per liter. Minus 8 mole per liter. Resting condition. And whenever there is action potential, it will rapidly reach to value of 10 to the power minus 5 mole per liter. And then these contractions will take place. This calcium will bind with this troponin C, and this activity of the troponin I, which is normally firmly bound with the actin, it becomes loosened, and there is a lateral displacement of the tropomyosin, and in this way they uncover this site where the myosin head can bind. And when this occurs, then there is increase in the myosin ATPase activity, there is liberation of the ADP and PI, and energy is produced. 7 per mole, 7.3 kilocalorie this mole, and there is the power stroke, conformational change. Yeah. Now after this power stroke, it is required that it should detach. Otherwise it will remain fixed in this way. And for this, there is another ATP molecule can bind, and another molecule of ATP can bind with the myosin head. So initially there is ATP, and that is liberated, products are liberated, but when it is in the relaxed state, then another ATP should come. To detach it. Suppose if there is single action potential, there is contraction followed by relaxation. And in that case also ATP is required to detach it. Now how relaxation, and in this way contraction is taking place. But then after this quick contraction, then there is relaxation. তোমরা বুঝতে পারছো না কিছু আমি যা বলছি? These are all easy things, very easy things. তোমরা যখন বই পড়বে দেখবে যে খুব সহজ জিনিস এগুলো। হ্যাঁ, তখন মনে হবে ক্লাসে যাওয়ার তো দরকার পড়ে না। বুঝতে পারছো? এবং ক্লাসে টাসে না গিয়েও তো অনেকেই পাস করে গেছে, সহজ জিনিস তো কিছু নেই, এমন কিছু জটিলতা কিছু নেই, বইয়ে দেখবে সব লেখা আছে সমস্ত। So during relaxation, detachments also require ATP, and it remains in that way, that is ATP plus PI, but it is remained in that position. This energy is not liberated. Energy is not liberated. So it is in the resting condition. Now this calcium ion that is entering, what should be the fate of this calcium ion? Whenever it is coming, then it is actively taken in within the longitudinal part of this L tubules. They will reaccumulate them in this. There is calcium, magnesium, ATPase. Actively transfer this calcium from the cytosol into the lumen of the, that is the L tubules, and they then diffuse to the terminal system, where there is calsequestrin protein that helps to maintain them stored at this site, storage site. So cytosolic concentration then again return back from this value to this. During contraction, it is in this action potential, and during relaxation, it is turned back to this. And then there is displacement of calcium from this, troponin C complex, and topomyosin will again recover the area for the myosin head attachment. And in this way, relaxation do take place. Now, there are also other proteins that are important in skeletal muscle, like actinin, alpha actinin. It helps to bind this actin molecule with the Z line, alpha actinin. And with the actinin, there are other proteins like nebulin also, parallel with this actin filament. Structural proteins, they are important. They help its proper synthesis also in this way. Now from the Z line to M band, there are this titin filament, TITIN, very elongated, very high molecular weight, 3 into 10 to the power 6 molecular weight, titin filament, and it has different types of structures, and that can be elongated, make them elastic. So initially, if they are stretching, they offer little resistance, but when the muscle is more, and their resistance increases. In this way, they help to maintain the length of this muscle, structural proteins. They are all intermediate proteins, they are called, and they are present. And their defect may be responsible for some rare cases of disease involving the skeletal muscle. Dystrophin is an important protein. And it connects these thin filaments, active filaments with the extracellular fluid proteins, dystrophin. And it is connected, and it is elongated type of molecule, elongated type of molecule, and there are numerous other proteins. That is this C-terminal, N-terminal, different types of ends, and it helps to, and dystrophin molecule with the merosin subunit of the extracellular fluid protein. That is the, and laminins, they are called laminins, that is the part is merosin, and this bind with this. Dystrophin. Different components, beta component, alpha component, that is it unites with the merosin component of merosin and laminin in the extracellular fluid, in the basal lamina, and this beta alpha, and in this way, there is this, and it is connected with the actin filament. Actin filament. There is a sarcoglycan component. Sarcoglycan component in the that is this plasma membrane. Sarcoglycan, alpha, beta, gamma, delta, sarcoglycan component. There are also other components you will find in the text, and they form a complex of proteins. Dystrophin is a rod-like structure in this way. And its deficiency is seen in clinical situations. Muscular dystrophy, Duchenne's muscular dystrophy, DUCHENNE, Duchenne muscular dystrophy, DMD, or when it is a X-linked recessive disease, and whenever the disease is less severe, there is another form of Becker's muscular dystrophy is there. Becker's muscular dystrophy. Muscular dystrophy are there. X-linked recessive disease. You can find in your clinical examination in the hospital. In the male babies, there this pseudo hypertrophy may be there. The muscles are weak, but they contain fibrous tissue. Apparently, you will have seen the hypertrophy from the outside, but in reality, they are weak. And it is dangerous when it involves the heart or the respiratory muscles, and longevity is lower than normal. Chronic disease, almost incurable. Duchenne's muscular dystrophy, and less severe form, that is the dystrophy, Becker's muscular dystrophy. Similarly, titins, in some cases, rare cases, there is deficiency in these titin molecules that from M line to Z line, titin molecules, and they are also, and that has been noted in some cases, rare cases. So these are these different parts of the muscle and excitation, contraction, coupling, and there is excitation and contraction and relaxation. It is important for the examination. There is from the beginning. I should not take the minute from the other class. Excitation, contraction, coupling, action potential in the neuron. At the neuromuscular junction, there is liberation of acetylcholine. Acetylcholine acts upon the ligand-gated channel nicotinic receptor, and there is initially there is a end plate potential, and it regularly reaches the action potential. Action potential will traverse to the T tubules, and by means of dihydropyridine receptor, there is liberation of calcium ion from the ryanodine receptor of the terminal cistern, and when its concentration increases, it unites with the troponin C moiety. Then there is this activity of the troponin I with the actins. Normally it is strong, and that is become loosened, and there is lateral movement of the tropomyosin molecule, and there is the exposure of the site over which the myosin head can bind, and there is liberation of energy, and there is some movement of the part of the head that connects with the branching part, elongated part, and it is called the power stroke. And in this way, contraction occurs on either side. It takes the help of other proteins. There are also desmins that combine with there is the actin filament to the filament. And these proteins are also helpful. And now, whenever there is single action potential, this calcium ion that comes out, and it is mopped by the L tubules by calcium magnesium ATPase. Another ATP must bind with that to relieve it this from this side for the detachment. And when the calcium ion concentration fall, then this calcium troponin C activation is terminated, and there is replacement of the tropomyosin to the original site and obscuring the myosin binding site, and relaxation occurs. In response to single contraction, it is called muscle twitch, and remaining part we will discuss the next week.
Lumbar nerves in the inferior extremity, which is more important, especially in clinical point of view. there are so many important nerves, and in your clinical practice, you will get patients in the outdoor with the nerve damage. So how do they present, and what are the anatomical reason behind for these defect? Just to know this, we have to know the nerves of the inferior extremity. I have already told you, to know any nerves, you have to categorize or divide this in the following headings. Number one, origin, root value. Root value of all the nerves are not required. Only the important root value of the important nerves are required. Then the course and distribution, branches, and then last but not the least, effect of clinical anatomy. So these are the, by way we read the nerves, whatever it may be, the superior extremity, whether it is present in the inferior extremity, whether it is present in the abdomen, head, neck, etc. This is the protocol. Origin, from where this nerve arise, root value of important nerves, then the course, how the nerve goes in our body, and then the branches and distribution, give branches to supply, and there are branches doesn't mean it only supplies a muscle. There is a tendency to write, whenever asked you the branches, you will write the muscular branches. But nerves not only a motor, muscular branches mean motor, but it also has got sensory component. So you have to mention the sensory part of the nerve, the cutaneous distribution of the nerve. You don't forget of any nerves, the cutaneous or sensory distribution. Cutaneous nerves, which carries the sensation from the skin of the defined part. So you have to write this. And also the articular branches to supply the nearby joints. So this is important. Then the clinical anatomy. When this nerve is damaged, what happens to a person? So these are the protocols. So to know the origin of the nerves of the inferior extremity, you have to know the lumbar plexus and a sacral plexus, which is actually a part of the abdomen, not in the inferior extremity, but without this you cannot go through. This is not time, so I have already described the lumbar plexus in last class. Just to recapitulate, I will give you some points so that you can understand the subsequent discussion. Lumbar plexus, already you have gone through the brachial plexus. You know, the brachial plexus is situated in the lower part of the neck and the axilla, which is formed by, I repeatedly tell you, anterior primary rami. When a spinal nerve comes out from the intervertebral foramen, from the vertebral column, it immediately divides into two. One is known as the anterior or ventral rami, and one is dorsal rami or posterior rami. Some say anterior primary rami and dorsal primary rami. And the plexuses are formed only by the anterior or ventral primary rami. Dorsal rami does not form any plexus. So brachial plexus is formed by the anterior primary rami of the C5 to T1 nerves. And lumbar plexus is formed by the anterior rami of the L1 to L4 nerves with a contribution from the T12 anterior rami of the T12 nerve. Another name of the T12 nerve or thoracic 12 nerve is known as the subcostal nerve. Already you know. So lumbar plexus is formed by the joining with each other. A network is formed. Look, a network is formed. A slight contribution above nerve, subcostal nerve give a contribution. Sorry. Give a contribution. Look, this is the subcostal nerve. It gives a contribution to L1 nerve. Anterior primary rami, L1 means lumbar 1. It is the lumbar 1 vertebra, lumbar 2, lumbar 3, lumbar 4, lumbar 5. So L1 nerve comes out the interval between the L and L2. So it gives a contribution to the L1 nerve, L2 nerve, L3 nerve, and L4 nerve, and this is the L5 nerve. ভালো করে দেখো, each L1 nerve, L2 nerve is into anterior division and a posterior division. So each L1 nerve, L2 nerve, L3 nerve, L4 nerve divides into anterior and posterior division. Then anterior division joins with the anterior division of the L2 and L3 in this way, and posterior division joins with the posterior division of L2, L3, L4, etc. In this way a plexus is formed. I have detail given in the last class. So L1, L2, L3, L4, L5. L5 এখন দরকার নেই, this is, and each L1 nerve divides into anterior and a posterior, anterior and a posterior, anterior and a posterior. Anterior division of L1, L2, L3 in this way, and posterior division in this way form a plexus. Ultimately from this plexus nerve arises. L1 nerve also, and it is the T12 nerve, L1, L2, L3, L4, L5. T12 gives a contribution to the L1 nerve, and L1 nerve again comes and divides into branches. Similarly, another branch comes from here. In this way, from this plexus, different nerves arises. I am not going into detail. So, in this way, plexus is formed. So, what are the L1 to L4? With a slight contribution of the T12 or subcostal nerve. This plexus is formed. And another important factor I have already told in last class about the L4 nerves. L4 nerves is a peculiar nerve. It divides into a anterior rami. I am not dealing with the posterior rami. Anterior rami L1 nerve, it divides into two branches, upper and lower. খুব ভালো করে দেখো, upper joins with the lumbar plexus. This is the lumbar plexus. Upper one joins with the lumbar plexus, and lower one, this is the L5 nerve. Lower one joins with the anterior rami of the L5 nerve and form a very important nerve known as the lumbocostal trunk or lumbocostal nerve, which joins with the lower nerves, S1 nerve, to form sacral plexus. So L4 nerve is a nerve which bifurcates, bifurcates to join the lumbar plexus above and the sacral plexus below as a lumbocostal nerve. So L4 nerve is known as the nervus furcalis, bifurcate. So it is the lumbus furcalis. And L5 nerve is a very important nerve which passing on the anterior aspect of the ala of the sacrum to join the sacral plexus. And this it is situated within the muscle fibers. That's when within the substance of the psoas major muscle. Psoas major muscle, it is the psoas major muscle. This is the psoas major muscle. By the side, it is the quadratus lumborum. So, and this is the iliacus muscle. This is the quadratus lumborum muscle. This is the iliacus muscle. কালকে আমি বলেছিলাম, কালকে একটা ওদের আসল একটা বলতেই ভুলে গেছি, নেক্সট দিন বলবো, ডরসাল অ্যাসপেক্ট অফ দ্য ইলিয়ামটাই বলতে ভুলে গেছি। আচ্ছা যাকে, সো দিস ইজ দ্য psoas major muscle, this is the iliacus muscle. খুব ভালো করে লক্ষ্য রাখো, this is the psoas major muscle, this is the iliacus muscle, and the groove The interval we call the iliopsoas groove. This iliacus and psoas muscle together comes under the, what is this? Inguinal ligament. Comes under the inguinal ligament and jointly joins with the, inserted into the lesser trochanter of the femur. So it is the iliopsoas groove. So it is the psoas major muscle. Psoas major muscle has got a medial border and a lateral border. Can you see the lumbar plexus here in this picture? Why? Because it is, lumbar plexus cannot be seen because it is present within the psoas major muscle. In the right side, the psoas major muscle is cut so that you can see the lumbar plexus. So, the lumbar plexus is present within the psoas major muscle and branches arises within the psoas major muscle. Then, it pierces, these branches pierces the psoas major muscle to come in different levels to come out. So, lumbar plexus is situated within the psoas major muscle or formation anterior rami of the L1, L4 nerve with a contribution of the TU12 nerve. Situation, it is situated within the psoas major muscle. Next, branches. Important branches are the iliohypogastric, ilioinguinal, then genitofemoral nerve. The L1 and L2 combine together to form a nerve known as the genitofemoral nerve, very important nerve. Ektu bole nei, this genitofemoral nerve comes down here and divides into a genital branch and femoral branch. So the name is genitofemoral nerve. Hey, পেছনে কি লিখছো তুমি? What are you writing? এই যে তুমি হ্যাঁ কি লিখছো? নোটস? আচ্ছা ঠিক আছে। না প্র্যাকটিক্যাল লিখছো হিস্টোলজি কে জানো? আচ্ছা ঠিক আছে, ইউজুয়ালি আমিও পড়তাম এটা। আমার আমার ওটাই ছিল, কারণ আমাদের সময় খুব চাপাচাপি ছিল, হিস্টোলজি না করে গেলে প্রেজেন্ট হতো না, মানে খুব এখন বলে আমরা বসতাম ওইখানটা পেছনে বসতাম আমি বড় পেছনে। আচ্ছা যাকগে, সো L1, L2 nerve form the genitofemoral nerve, very important nerve. It comes down here. Ultimately, এটা কিন্তু within the psoas major muscle, ভালো করে লক্ষ্য করো, অ্যাবডোমেন একটু পড়িয়ে নিচ্ছি, within the psoas major muscle, so you cannot see the formation. এই বুঝতে পারছো তো সবাই? আমরা কিন্তু এই জায়গাটা দেখতে পাবো না অ্যাবডোমেন ওপেন করলে, কাটলেই দেখতে পাবো। Then it pierces the psoas major muscle and comes out to lie on the psoas major muscle. It is the identification point of the, যখন অ্যাবডোমেন করবে এটা কিন্তু অস্পিতে থাকবে, এই জেনিটোফিমোরাল নার্ভের এখানে সুতো বাঁধা হয়ে এইখানে থাকবে। হোয়াট ইজ দ্য নার্ভ? আইডেন্টিফাই যে with that nerve which lies on the psoas major muscle on its anterior aspect, it is the genitofemoral nerve. This genitofemoral nerve then divides into a genital branch and a femoral branch. দেখতে পাচ্ছ কি? A genital branch which enters the deep inguinal ring, traverses the inguinal canal, এখন বুঝতে পারছো না, and then comes in the scrotum to supply the trimester muscle present in the scrotum and also the sensory supply in the anterior third of the scrotum and or labium majus in female. এটা পড়ার দরকার নেই এখন, don't read now. Read this, the femoral branch. Femoral branch comes under the inguinal ligament within the femoral sheath. Femoral sheath এর মধ্য দিয়ে বের হচ্ছে, arterial যেখান দিয়ে artery আছে সেখান দিয়ে বেরোবে। Then it pierces the femoral sheath to come out and to supply the skin on the upper part of the anterior aspect of the thigh. So femoral branch, it carries the sensation from the upper and slightly medial aspect of the skin of the thigh. And আগে কি বলেছি একটা শুধু বলে নেই, this genital branch supply the cremaster muscle. Cremaster muscle is related to the testes. ভেতরে আমাদের স্ক্রোটামের মধ্যে টেস্টিস থাকে, ফিমেলের এই রিফ্লেক্সটা হবে না, কেমন testis থাকে. Cremaster muscle is a muscle surrounds the testis. When it contracts, the testis pulls up, testis goes up, ওপরে উঠে যায়. সুতরাং to know whether the L1 nerve is functioning, we do a test, especially in the children, known as the cremasteric reflex. আমরা এনি রিফ্লেক্সের কি থাকে, একটা অ্যাফারেন্ট লুব, তাই তো ফিজিওলজিতে পড়েছে, একটা অ্যাফারেন্ট নার্ভ, স্পাইনাল কর্ডে একটা সেন্টার, দেন দ্য ইফারেন্ট হুইচ সাপ্লাই এ মোটর মাসল. Afferent is a sensory. So we stroke the upper part of this hair, যেখানে ফিমোরাল ব্রাঞ্চটা সাপ্লাই করেছে. It carries the sensation to the L1 or L2 spinal segment. Then, so which carries the afferent lobe? Femoral branch of the genitofemoral nerve. L1, L2 spinal segment then orders cremaster to act. So these order carried by the again genitofemoral nerve by its genital branch, which causes stimulation of the cremaster muscle, which pulls the cremaster up, so that you can easily, especially in children, see the testis is pulled up, uthe geche. So this is known as the cremasteric reflex. If it is a present, L1, L2 spinal segment is okay. If it is absent, there is some difficulty. Either the femoral branch or the L1 root or the genital branch is defective. So this is known as the cremasteric reflex. Afferent lobe is the femoral branch of the genital nerve. Center is the spinal segment of the L1, L2, and efferent is the genital branch, ভুল বলেছি, afferent is the femoral branch of the genitofemoral nerve, center is the L1, L2, and efferent is the genital branch of the genitofemoral nerve. So it is a very important nerve, genitofemoral nerve, তার জন্য ডিটেলসে বললাম, which carries, not only carries the sensation in the upper part, but also a reflex is formed by the cremasteric reflex. আজকে একটা কোশ্চেন দিয়েছিলাম অসপিতে, কেউ অনেকেই লিখতে পারোনি, জানি না, যে বাইসেপস রিফ্লেক্সটা আমি চেয়েছিলাম, যে বাইসেপস একটা টেন্ডন ফার্স্ট ডেতে দিয়েছিলাম, যে হোয়াট ইজ দ্য, যারা ফার্স্ট ডেতে দিয়েছে, হোয়াট ইজ দ্য স্ট্রাকচার, ইট ইজ দ্য বাইসেপস মাসেল, তারপরে তার মাসেল অরিজিন ইনসার্শন দিয়ে লাস্টে দিয়েছিলাম হোয়াট রিফ্লেক্স ইজ সাবসার্ভ অ্যান্ড হোয়াট স্পাইনাল সেগমেন্ট ইজ ইনভলভ, হবে বাইসেপস রিফ্লেক্স, ভেরি ইম্পর্টেন্ট রিফ্লেক্স. দেখবে প্রত্যেক আউটডোরে তোমাদের করবে, এখানে মারবে, এই যে উঠছে, দিস ইজ নোন অ্যাজ দ্য বাইসেপস রিফ্লেক্স, ইজ ক্যারিড বাই দ্য C5C6. তোমরা জেনে নেবে এইখানে C5C6 সেগমেন্ট ইজ ওকে ইফ দ্য বাইসেপস রিফ্লেক্স ইজ ওকে. তো অ্যানাটমি তো দ্যাট ইজ দ্য অ্যানাটমি. You have to corroborate with the clinics, otherwise know everything. Quadratus femoris ei jacche, o nerve quadratus femoris ঘুরে যাচ্ছে, what is the use if you not a good doctor? Anatomy means doesn't mean the boring anatomy. You must use the anatomical knowledge in practical field. Here is the cremasteric reflex. আজকে যাদের আছে হয়তো হোল লাইফ ভুলবে না, যে বাচ্চাদের যদি আমরা ভাবি L1 সেগমেন্টে কোনো গন্ডগোল আছে, if we before a poor patient don't afford for MRI, you can easily know by this cremasteric reflex that L1 is present or not. Is there any damage of this spinal segment or not? So this is the anatomy. Not that the femoral obturator nerve, a branch, what is the, age amader this type of questions asked, waiting, how does it end, how does it end? Now branching the supply the femoral artery, monei nei amader, it is not no use. এইভাবে পড়বে তোমরা. So this is the জেনিটোফিমোরাল নার্ভ। তাহলে কি কি ব্রাঞ্চ বললাম? ইলিও হাইপোগ্যাস্ট্রিক, ইলিও ইঙ্গুনাল, জেনিটোফিমোরাল। There's another important nerve, lateral femoral cutaneous nerve of thigh. যখন ফিমোরাল ট্রায়াঙ্গেল করবে প্রত্যেকটা কাজে লাগবে। ল্যাটারাল ফিমোরাল কিউটেনিয়াস নার্ভ অফ থাই, এখানে এঁকেছে কি? এঁকেছে। Look, again value is the L2, L3. This is L2 and L3 posterior division joined to form a lateral femoral cutaneous nerve which passes over comes out from the lateral border of the psoas major muscle. Lateral border in upper part, psoas major muscle comes laterally and passing below the inguinal ligament, just kalke jeta bolechhilam, just below the anterosuperior iliac spine. In the notch, there is a notch between the anterosuperior iliac spine and anteroinferior iliac spine. বলেছিলাম তো, there is a notch, a notch দিয়ে পাস করছে। To comes out in the thigh to supply the cutaneous sensation of the lateral aspect of the thigh. এই জায়গাটা। So lateral femoral cutaneous nerve, and there is a clinical anatomy there. As it passes below the inguinal ligament, there is a chance of compression of this nerve. এই যে একটা ছোট্ট জায়গা দিয়ে একটা নচ এখান দিয়ে নার্ভ যাচ্ছে, ওপরে ইঙ্গুইনাল লিগামেন্ট। সো ইন সাম পারসনস দেয়ার ইজ অ্যান প্রেশার এফেক্ট। ওই জায়গাটা যদি কোনো কারণে নার্ভ সোয়েলিং হয় অথবা যদি ফ্র্যাকচার হয় ইলিয়াক বোনের কাছে, this nerve may be compressed or damaged, leading to, as it is a cutaneous supply, severe sensory disturbances, severe pain or altered sensation over the lateral part of the thigh as it supplies the upper part of the lateral part of the thigh, and this condition known as meralgia paresthetica. Meralgia paresthetica সব বইতেই আছে দেখবে, meralgia paresthetica. Anesthesia means absence of sensation. If there is no sensation, we call anesthesia. And paresthesia means altered sensation. আমরা নর্মাল যেটা আমার এখন হচ্ছে দিস ফিঙ্গারে, এই যে দিচ্ছি একটা সেন্সেশন আছে, যদি অল্টার্ড হয়, অন্যরকম হয়, we call paresthetica, paresthesia. So there is an altered sensation as due to compression of the lateral femoral cutaneous nerve of thigh, and we call it meralgia paresthetica. গেল। এরপরে দুটো ইম্পর্টেন্ট নার্ভস বলছি। একটা হচ্ছে comes out from the medial border of the piercing the medial border of the psoas major muscle and passing under the inguinal ligament, but not through the femoral sheath, and it is the femoral nerve. Femoral nerve is not a content of the femoral sheath. Femoral artery, femoral vein, আমি আগের দিন বলেছিলাম ডিটেলসে, is a content of the femoral sheath, and femoral nerve is not a content of the femoral sheath. It is outside the femoral sheath, but it passing under the inguinal ligament. So it comes out at the medial border of the psoas major muscle, and it is formed by the, আগেই বলেছিলাম, L2, L3, L4 divides into anterior and posterior division. বলেছিলাম তো, the posterior division of the L2, L3, L4 join together to form the femoral nerve. Here the root value is important. So root value is important for genitofemoral nerve, root value is important for femoral nerve, root value is important for obturator nerve. So dorsal division of the anterior primary rami of L2, L3, L4 forms the femoral nerve, which comes out from the medial border of the psoas major muscle, passing under below the inguinal ligament. Then it divides into anterior and posterior division, পরে আসছি। Then the anterior division of the L2, L3, L4 nerve. L2, L3, L4 আমি বারবার বলছি anterior division and posterior division. Posterior division of the L2, L3, L4 join together to form the femoral nerve. So root value of the femoral nerve is L2, L3, L4. And anterior division of the L2, L3, L4 join together to form a obturator nerve. So root value of the obturator nerve is same L2, L3, L4. Only difference, femoral nerve forms by the dorsal division and obturator nerve is formed by the ventral division. So root value of the femoral nerve and a obturator nerve are same L2, L3, L4. Important. So it comes out from the lateral border of the psoas major muscle, enter the thigh and supply the medial aspect muscles and medial aspect of the thigh. তাহলে এটা হয়ে গেল obturator nerve. So these are the important branches of the lumbar plexus. এছাড়া অনেক সময় from the third and lumbar nerve, not in all persons, হয়তো তোমাদের মধ্যে একজনের third and fourth lumbar nerve join to form another nerve known as the accessory obturator nerve. Present, but not always. এটা বলে দিয়েছি Melalgia paresthetica is a pain or burning sensation felt over the anterolateral aspect of the thigh, usually caused by compression of the lateral femoral cutaneous nerve, often asked in the oral examination or OSP. Genitofemoral nerve root value L1, L2. আচ্ছা এরপরে নেক্সট আমি ডেসক্রাইব করব ফিমোরাল নার্ভ। আগের দিন বলেছিলাম খুব শর্টে বলবো। ফিমোরাল নার্ভ বলার আগে তোমরা এখনো ডিসেকশন করনি তার জন্য বলে নিচ্ছি, ছবিটা দেখাচ্ছি। দেয়ার আর মাসলস ইন দ্য anterior aspect of the thigh. What are the muscles? Number one, anterior muscle, of is the most important muscle, obliquely crossed from anterior superior iliac spine to be inserted in the medial border of the tibia, that is the sartorius muscle. দেখতে পাচ্ছ? Obliquely crossing all other muscles from origin anterior superior iliac spine, বলেছিলাম কালকে anterior superior spine to one muscle, one ligament. This is the sartorius muscle. A ligament is inguinal ligament. Then it goes obliquely crossing from lateral to medial side. Then it inserted into the medial upper part of the medial surface of the tibia, sartorius. Then there is another muscle. The four muscles are there. Rectus femoris. Rectus femoris has got two heads of origin, straight head and reflected head. Straight head arises from the key. Very good, very good. Anterior-inferior iliac spine. Come on. And reflected head arising, bolte bhule gechi kalke, just above the acetabulum. Reflected head. Acetabulum cavity opore hocche reflected head. Come on. From that origin, it comes as a muscle. This is the rectus femoris. And there are three vasti muscle. Vastus singular, vasti plural. Vastus medialis, which is present medially. Vastus lateralis, এবং ভেতরের দিকে থাকে vastus intermedius. This rectus femoris, vastus medialis, vastus lateralis, and vastus intermedius, these four muscles are called together quadriceps femoris. Quadriceps femoris. এই যে quadriceps exercise, quadriceps injury to a football or rugby player, এই quadriceps muscle. They ultimately join together to form a single tendon. known as ligamentum patelli, which is inserted into the patella. And so this is that vastus also has got a insertion in the patella. Pore porbe. Acha. So these are the quadriceps muscle. And there are other muscles here. Extreme medial muscle. It is known as the gracilis. কালকে বলেছিলাম anterior aspect of the body of the pubis থেকে এবং ischiobut থেকে নিচ্ছে, তার তলে রয়েছে adductor longus, adductor brevis and adductor magnus. এখানে দেখা যাচ্ছে না ভালো, পরে ফিগার আছে ভালো দেখাবো. So these are the muscle. So these muscles and here like the iliaca, pectineus, iliacus and psoas muscle. পরে আবার দেখাবো. So these are the muscles, of which anterior group of muscles are these. Quadriceps muscles are known as the anterior group of muscles. And also iliacus, pectineus are also regarded as the anterior group of muscles. But pectineus is the position is such, it both acts as anterior and a medial group. And medial group of muscles ki? Gracilis, adductor longus, adductor brevis, adductor magnus, obturator internus and obturator externus are known as the medial group of muscles. এটা জানতে হবে. এইটুকুনি বলে আমি এবার femoral nerve যাচ্ছি. So femoral nerve after its origin comes out under the inguinal ligament, enter the thigh and immediately divide into two divisions, anterior division and a posterior division. Before dividing from this trunk, it gives two branches. Before it divides into anterior division and posterior division, it gives small branches which supply the iliacus muscle and the pectineus muscle. আমরা পরে আসবো. Pectineus is a hybrid muscle. Hybrid muscle কি? If a muscle is supplied by two nerves, we call hybrid muscle. যেমন ব্রেকিয়ালিস এখানে হাইব্রিড মাসেল, বুঝতে পারলে? ফ্লেক্সার আরেকটা মাসেল হাইব্রিড আছে, বলো, ঠিক বলেছো, হ্যাঁ, ফ্লেক্সার ডিজিটারাম প্রফান্ডা ইজ আ হাইব্রিড মাসেল. এগুলি ছোট্ট করে বইয়ের পাশে নোট করে রাখবে বা একটা আলাদা খাতা করবে, ট্রিকি জিনিসগুলি হাইব্রিড মাসেল এগুলি নোট করে রাখবে যাতে পরীক্ষা ওরালের সময় দেখে যেতে পারো. আচ্ছা, সো দিস ইজ দ্য ফিউমারাল শীথ. এই ফিউমারাল শীথের বাইরে দিয়ে বেরিয়ে গেল এবং বিফোর ডিভাইডিং ইট গিভস নার্ভ টু ইলিয়াকাস, নার্ভ টু পেকটিনিয়াস টু সাপ্লাই দ্য ইলিয়াকাস অ্যান্ড পেকটিনিয়াস মাসেল. এরপরে দেন ইট ডিভাইডস ইন্টু অ্যান্টেরিয়র ডিভিশন অ্যান্ড এ পস্টেরিয়র ডিভিশন, অ্যান্ড বিটুইন দ্য টু ডিভিশন one artery is present. এইটা আবার নোট করে রাখবে, lateral femoral circumflex artery. So what lies between the two divisions of the femoral nerve? Answer, lateral femoral circumflex artery. For MCQ, for oral. What lies in between the two division of the কি বললাম of the femoral nerve? Answer, lateral femoral circumflex artery. What is lateral femoral circumflex artery? তোমরা জেনে যাবে একটু পরেই, যাকে এই দেখছো femoral sheath. This is the femoral sheath. এই femoral sheath এর কিন্তু বাইরে. This is the lateral border of the femoral sheath, তার বাইরে. আচ্ছা, এরপরে দেখতে পাচ্ছ ফ্রম দ্য অ্যান্টেরিয়র ডিভিশন দেয়ার আর সো মেনি ব্রাঞ্চেস অ্যারাইজেস অ্যান্ড ফ্রম দ্য পস্টেরিয়র ডিভিশন সো মেনি ব্রাঞ্চেস অ্যারাইজেস. কি করে মনে রাখবো? আগের দিন বলে দিয়েছি, কেউ বলো? শর্টকাট অ্যান্ড কোয়াড্রিসাপ. শর্টকাট অ্যান্ড কোয়াড্রিসাপ জীবনে ভুল হবে না, হোল লাইফে. ফ্রম দ্য অ্যান্টেরিয়র ডিভিশন হচ্ছে শর্টকাট, এই দুটো মনে রাখবে। শর্টকাট, অ্যাকচুয়ালি এইচ স্টার বললাম না, শর্টকাট মিন কি? এস, নাভ টু সার্টোরিয়াস। এস ফর সার্টোরিয়াস, কাট মিনস কিউটিনিয়াস। এবার কিউটিনিয়াস কি বাকি থাকছে? ল্যাটারাল তো দিয়েই দিয়েছে। ফ্রম দ্য লাম্বার প্লেক্সাস ল্যাটারাল পার্ট ইজ সাপ্লাইড বাই দ্য ল্যাটারাল ফিমোরাল কিউটিনিয়াস নার্ভ। আর দুটো কিউটিনিয়াস নার্ভ বাকি থাকছে, intermediate and medial. So, cut means medial cutaneous nerve of thigh, medial cutaneous nerve of thigh, and তোমরা লিখে নাও, আর একটা হচ্ছে intermediate cutaneous nerve of thigh, medial cutaneous nerve of thigh and intermediate cutaneous nerve of thigh. এরপর হচ্ছে কোয়াড্রিসেপ। কোয়াড্রিসেপ মানে বুঝতে পারছো, কোয়াড্রি মিন্স কোয়াড্রিসেপস মাসল। কোয়াড্রিসেপ, কোয়াড্রি মিন্স quadriceps muscle. So nerve to rectus femoris, vastus medialis, vastus intermedius, vastus lateral. Sap means a sensory nerve, saphenous nerve. তাহলে খুব কঠিন মনে হচ্ছে কি ফিমোরাল নার্ভের ব্রাঞ্চ? মনে রাখা একদম নয়, শুধু মনে রাখবে, ভুলে যাবে না নার্ভ টু এই যে ইলিয়াকাস অ্যান্ড পেকটিনিয়াস ফ্রম দ্য ট্রাঙ্ক। সো অ্যান্টিরিয়র ডিভিশন শর্টকাট, posterior division, here now, quadricep. তার মধ্যে saphenous nerve is the cutaneous nerve and it is the longest cutaneous nerve of the body. আবার ছোট্ট করে লিখে রাখবে, longest cutaneous nerve in the body. একদম টো অবধি সাপ্লাই করে মিডিয়াল সাইডে। আচ্ছা, ফিউমাল শীট বলে দিয়েছি। এগুলি পরে পড়ে নেবে, তোমাদের এখন দরকার নেই। তাহলে ইনজুরি টু দ্য ফিমোরাল নার্ভ যদি কোনো কারণে হয়, দো রেয়ার, but still may happen, তাহলে কি কি হবে? ইলিয়াকাস, সার্টোরিয়াস, পেকটিনিয়াস এফেক্টেড হবে, তার জন্য ফ্লেকশন অফ দ্য হিপ এফেক্টেড হবে, ফ্লেকশন অ্যান্ড অ্যাডাকশন অফ দ্য হিপ এফেক্টেড হবে, এবং এটা পার্শিয়ালি এফেক্টেড হবে। সবচেয়ে এফেক্টেড হবে এক্সটেনশন অফ দ্য নি। এই এক্সটেন্ড করতে পারবে না, ভালো করে এক্সটেন্ড করতে পারবে না, খুব রেয়ার, পরীক্ষায় দেওয়া হয় না, তাও জেনে রাখো। আচ্ছা, কিউটিনিয়াস নার্ভ অফ দ্য থাই যদি বলে, এই ল্যাটারাল পার্ট, এটা ল্যাটারাল কিউটিনিয়াস নার্ভ, ইন্টারমিডিয়েট পার্ট অফ দ্য ইন্টারমিডিয়েট কিউটিনিয়াস নার্ভ, অ্যান্ড মিডিয়াল কিউটিনিয়াস নার্ভ অফ দ্য থাই করে। এবং আপার পার্টে দুটো নার্ভ আসে, একটা আগেই বলেছি ফিমোরাল ব্রাঞ্চ অফ দ্য জেনিটোফিমোরাল নার্ভ, আর একটা হচ্ছে ইলিওইঙ্গুনাল নার্ভ। আচ্ছা, saphenous nerve. Saphenous nerve is the longest cutaneous nerve. এখন ডিটেলস বলছি না। It supply from the posterior division of the femoral nerve. Then it passes medially, passes here, and ends passing along the medial border of the T and ends at the ball of the great toe. দেখো কতটা বড়, and supply the cutaneous sensation over this region. So medial margin of the sole is supplied by the femoral nerve. এটা মনে রাখবে। এরপরে নেক্সট নার্ভ যেটা হচ্ছে অবটুরেটর নার্ভ। Obturator nerve is formed by the ventral division of the L2, L4 nerve. It comes out under the lateral border of the psoas major muscle, under the inguinal ligament, and enters the medial compartment of the thigh. And again it divides like a femoral nerve into anterior and posterior division. খুব ডিটেলস পড়ার দরকার নেই। আমি এটা স্যাজিটাল সেকশন। লুক দিস মাসল, আগে কি বলেছি, এই মিডিয়াল কম্পার্টমেন্টে গ্রেসিলিস ছাড়া কি কি মাসল রয়েছে? অ্যাডাক্টর গ্রুপ অফ মাসল, অ্যাডাক্টর লঙ্গাস, অ্যাডাক্টর ব্রেভিস, অ্যাডাক্টর ম্যাগনাস। অ্যাডাক্টর ম্যাগনাস একটা পিকুলিয়ার মাসল। কি মাসল? অ্যাডাক্টর ম্যাগনাস হ্যাজ গট এ ডুয়াল অ্যাকশন। It both belongs to adduction medial compartment or adductor of the hip joint, adduction korche. Come on, pore porbe, this is the adduction, this is the abduction. And also it belongs to the hamstring group. So adductor magnus has got a adductor component and a hamstring component. Hamstring are the muscles present in the posterior part of the thigh. Ashbo ami. So, anterior division, this is the adductor pectineus, this is the adductor longus, this is the adductor magnus, and this is the adductor brevis. তাহলে কে হচ্ছে সুপারফিশিয়াল? অ্যাডাক্টর লঙ্গাস। তারপরে কে রয়েছে? অ্যাডাক্টর ব্রেভিস। তারপরে কে রয়েছে? অ্যাডাক্টর ম্যাগনাস। এরম ভাবে একটার পর একটা। এটা যদি অ্যাডাক্টর ম্যাগনাস হয়, অ্যাডাক্টর ব্রেভিস, অ্যাডাক্টর লঙ্গাস, তারও উপরে রয়েছে পেকটিনিয়াস। এরম ভাবে অ্যাডাক্টর ম্যাগনাস, পেকটিনিয়াস, অ্যাডাক্টর লঙ্গাস, অ্যাডাক্টর ব্রেভিস and adductor magnus. And obturator nerve comes here and divides into anterior division and a posterior division. Anterior division comes below the pectineus but superficial to the adductor longus, and posterior division passing between the adductor, bhul bollam, passing, and adductor brevis is the main key boundary between the anterior and posterior division. Anterior division passing superficial to the adductor brevis and posterior division passing posterior to the adductor brevis. Mone rakhbe. So anterior division passing superficial to the adductor brevis and posterior division passing posterior to the adductor brevis. So anterior division, it supplies the pectineus and adductor longus and also the gracilis. And posterior division supply the adductor brevis and most important adductor magnus. So pectineus has got a dual supply, both by the femoral nerve and the obturator nerve. So pectineus is a hybrid muscle, both supplied by the femoral nerve and the pectineal nerve, obturator nerve. And most important, jeta important, last bolchi, femoral nerve আগেই বলেছি, শুধু কিউটিনিয়াস ইম্পর্টেন্ট সাপ্লাই নয়, শুধু মাসল সাপ্লাই নয়, another important supply of all muscles is the joint supply. Both femoral and, ভালো করে এটা শুনো, ক্লিনিক্সে লাগবে, both femoral and knee joint, both hip joint and knee joint are supplied by both femoral and obturator nerve. তোমরা যখন সাবসার্টোরিয়াল প্লেক্সাস পড়বে তখন বুঝতে পারবে। So both hip joint and knee joint are supplied by both obturator nerve and a femoral nerve. So এইবারে ইন্টারেস্টিং পয়েন্ট, any pathology of the hip joint, জয়েন্ট, এই জয়েন্টে আর্থ্রাইটিস হয়েছে, পেশেন্ট বলছে আমার নি জয়েন্টও, নি জয়েন্ট ইজ ওকে, টোটালি নর্মাল, পেশেন্ট বলছে নি জয়েন্টও ব্যথা, রেফার্ড পেইন, রেফার্ড পেইন চলে গেছে। আবার নি জয়েন্টে ব্যথা হলে হিপ জয়েন্টে ব্যথা হবে। ওভারি ফিমেলের is present on the iliac fossa and obturator nerve closely related to it. So any ovarian pathology may compress the obturator nerve. ওভারিতে প্যাথোলজি হয়েছে, পেশেন্ট বলছে আমার নি জয়েন্টে ব্যথা হচ্ছে। তাহলে এগুলি কি? এগুলি হচ্ছে অ্যানাটমি অ্যান্ড ক্লিনিক্যাল অ্যানাটমি, মাথায় রাখতে হবে। কোয়াকদের সাথে এখানেই ডিফারেন্স। একটা নি জয়েন্ট পেন নিয়ে এসেছে, ইউ এক্সামিন করলে অল ওকে, এক্স রে করলে অল ওকে, পেশেন্টের স্টিল পেশেন্ট কমপ্লেইন অফ পেইন হচ্ছে বা হিপ জয়েন্টে পেইন হচ্ছে, দেন ইউ মাস্ট হ্যাভ এ স্ট্রাইক দ্যাট মাইট বি ওভারিয়ান প্যাথোলজি। তখন পেশেন্ট সব সিমটম কিন্তু পেশেন্ট উইল নট টেল বিফোর এ ডক্টর, দেন উই আস্ক, give leading question, then patient admit there's some problems in my menstruation and other, some pain is here. So this is the clinical anatomy. Referred pain is a very important pain. A cardiac pain referred here, a cardiac pain referred, first patient complaint made toothache, just toothache, এখানে pain বলছি না। This is the beauty of the referred pain. So this is the obturator nerve, আর এগুলো যাবে না মনে হচ্ছে। তাহলে বাসেলস অ্যান্টেরিয়র ডিভিশন কি কি সাপ্লাই করছে? পেকটিনিয়াস গ্রেসিলিস, অ্যাডাক্টার লঙ্গাস অ্যান্ড অ্যাডাক্টার ব্রেভিস অকেশনালি, অ্যান্ড posteriorly obturator, আরেকটা বলেছি, obturator externus is supplied by the posterior division, adductor brevis and adductor magnus. adductor magnus এর কোন পার্ট সাপ্লাই করে? অ্যাডাক্টার পার্ট। তাহলে অ্যাডাক্টার ম্যাগনাস ইজ এন হাইব্রিড মাসল। আগেই বলেছি অ্যাডাক্টার ম্যাগনাস হ্যাজ গট এ অ্যাডাক্টার কম্পোনেন্ট অ্যান্ড এ হ্যামস্ট্রিং কম্পোনেন্ট। সো অ্যাডাক্টার পার্ট অনলি which takes origin from the femur, which only is supplied by this obturator nerve, and hamstring part is supplied by the tibial component of the sciatic nerve. তাহলে অ্যাডাক্টার ম্যাগনাস ইজ অলসো হাইব্রিড মাসল। তাহলে অলরেডি তোমরা অনেকগুলি হাইব্রিড মাসল পেয়ে গেলে। দিস ইজ দ্য অ্যাডাক্টার ব্রেভিস, দিস ইজ দ্য পেকটিনিয়াস সুপারফিশিয়াল, অ্যাডাক্টার ব্রেভিস, অ্যাডাক্টার লঙ্গাস, অ্যাডাক্টার ম্যাগনাস। এইভাবে থাইতে যখন ডিসেকশন করবে দেখবে। This is the supply. Anterior division is in front of the adductor brevis, posterior division behind the adductor brevis. Anterior division supplies pectineus, adductor longus, occasionally adductor brevis. Posterior division supply adductor magnus, adductor brevis and obturator externus.
Big red. That means when the urine sugar is present in less amount, urine sugar means by and large it's urine glucose until proved otherwise. Until proved otherwise means there is no other cause. Like you know by this time that lactose can give false positive result. Any reducing sugar, including drugs, vitamin C, I have demonstrated it. So that gives an idea of some amount of quantity that is semi-quantitative. That's not the real quantitation. Today you will measure plasma glucose, what is actually done in laboratory. So for that, why you will be required to know all these things in detail? Because I, as a clinician, none of you will practice this laboratory estimation or this urine glucose sugar, this urine strip testing. Your role will be to monitor and to find out the faults. For that you must have a thorough knowledge, because these all will be done by the technicians who are not only less qualified, less well aware of the facts, having less knowledge also. So at times they will commit mistake. And if you are not aware of the real procedure, you have to accept their findings. Finally, you will be the treating the patients. So whatever the responsibility, that is called a vicarious responsibility, once you take care of the patient, patient is directly under you. And fortunately, if you are the only person, you have to own the entire responsibility for anything. In a hospital setup where somebody is bigger, holding a higher post under which you are working, like HOD by his position is responsible for the misconduct done by you. Similarly, anything which is done by the technician, which is done by the nursing staff, finally is your responsibility. Because you have asked for blood sugar estimation, blood glucose estimation, and suppose the sample has been drawn wrongly, or the sample has been reported wrongly by the laboratory. At the end of the day, or after this laboratory report is sent, you will see the report, and if you are not satisfied, then you must ask for a repeat examination, and you have to analyze the cause. And the cause is usually with either with the nursing staff or with the paramedical staff who has drawn the blood, or there might be a problem in the laboratory itself. So that thorough knowledge of everything is required. See, there are many things which need to be told, but because of the shortage of the time, I am unable to tell. At this stage, you must know the principle of estimation of glucose. That is the first slide which I will be showing will be important for your own class. Suppose if you don't know the procedure, you cannot go and pinpoint where is the fault. So with that brief introduction, because I will start this glucose estimation, that is where is. Let me show. Please do not write all these things right now. I'll ask you to write down. First you understand, and if you do not understand, you let me know where is your problem. I'll give you enough time to write down. Today, basically, I'll be demonstrating you, and the next day you will be giving a hands-on training. You will do it with your own hands. So first, what is the principle of estimation? These two slides you have to write down. First you understand right now. Give a little space and then write first this one. Then you will write on top of which this one. Okay? Give a little space. Write down quantitative estimation of plasma glucose. The same procedure can be used for blood glucose estimation in serum and also body fluids. That is, there are several body fluids, something like CSF, cerebrospinal fluid, ascitic, pleural, and pericardial. Right on the top, this quantitative estimation of plasma glucose. Glucose is estimated from plasma, as I told in the diabetes class. It can be done by the serum, but that is not a recommended procedure. Why I will tell you. And this is basically a colorimetric estimation by glucose oxidase and peroxidase method. You write down this much. Then you understand, then you write down. Okay. Now give a little gap and write down this part. Glucose plus oxygen, glucose oxidase to gluconic acid plus hydrogen peroxide. Write down a little rapidly so that we can discuss something more which will be clinically relevant. But these two slides will be for you only, exclusively, for the examination purposes and at your level. And second stage is H2O2, AAP, phenol, quinoimine dye, peroxidase, and water. This much you write down. All of you must note down. Never use any mobile. Do not take any picture. You just write down. I want you should write down this thing. So this will be asked during examination, and I think in all probability blood glucose estimation will be given, and this principle will be asked. Have you completed? Please start a little faster, because otherwise you will not be able to leave before 1 o'clock. Yesterday it crossed at about 1:15. So during enzyme class, I have told one aspect of uses of enzymes. Apart from many uses, that is ELISA and these uses of the after heart attack, that urokinase and tenecteplase, I told also it can be used for diagnostic purposes. Now this is the real use of enzyme. We are using enzyme for glucose estimation. Glucose oxidase and peroxidase both are enzymes. Now we are estimating glucose. Why? Why this method is required? See, glucose, if I dissolve in water, I will not be knowing what is the concentration. Suppose I have dissolved 100 milligram of glucose in 100 ml solution in one test tube or one glass, 200 in one, 300 in one, 400, 500 and 1000. If I mix it thoroughly and if I show you the glass to you, it will look like a distilled, just like water. You will not be able to know what amount of, forget about glucose. Whether glucose is present or not, you will not be able to tell. And in the blood, apart from glucose, there are many substances like urea, cholesterol, creatinine, uric acid, sodium, potassium, calcium, phosphorus, all enzymes, what not. So these are present in the plasma. So we have to select a method which will specifically detect glucose if we want to measure glucose. Similarly, if we want to measure cholesterol, we have to again select a method which will categorically or very specifically measure cholesterol or urea. Here our interest is basically glucose. So in the first reaction, because since it is not visible, I repeat one thing. One day I told you that as a clinician, what you will see with your naked eyes and maybe with some stethoscopes or some instruments. So which is visible by the naked eye is usually done by the clinicians. That which cannot be seen by the naked eye, but you require a microscope, that comes under the purview of pathologist. But which can neither be seen nor by using a microscope, but requires a biochemical reaction, comes under the purview of biochemistry. So glucose, cholesterol, triglyceride, uric acid, you cannot see under the microscope. So for that, we have to adopt this biochemical method. So this glucose, which is really not visible, is allowed in the first reaction. So now with the glucose oxidase to form gluconic acid. At this stage you do not write, I will give you time, just understand. So basically glucose is converted to gluconic acid and hydrogen peroxide. Now we are taking hydrogen peroxide from the first reaction and we are allowing it to react with amino antiphenazone and phenol to form a pink colored compound quinamine dye with the help of enzyme peroxidase. That dye will form a color. So the amount of glucose which is present, which will be proportional to the amount of quinamine dye. Because suppose if 100 milligram of blood glucose gives 100 milligram, suppose 100 milligram of quinamine H2O2, then 100 milligram of H2O2 will give 100 milligram of quinamine dye. Similarly, if it is 200, it will be double. If it is 400, it will be double, and you will see this color in your practical class. Some of you of your batch who attended last week has seen a standard level with 100 and 400. What is the difference between this intensity of the color? The more in the intense the color, higher the concentration. So now you write down in the first step what we are doing. In the first step, glucose present in the sample. The sample in this case is plasma, not serum, but it can be measured by serum. Will be converted to gluconic acid and hydrogen peroxide by glucose oxidase enzyme. Write down this thing. This is required. Only this part you must remember. What is the principle of estimation of glucose? In the second step, hydrogen peroxide will react with 4 amino antipyrine and phenol to form a pink colored quinamine dye, which you will see today. So the intensity of the color of quinine dye in that particular solution is proportional to the amount of glucose in the sample. Is this part clear? Is this part clear to everybody? If this is not, then I am going to repeat again. Has everybody understood clearly? So you must be able to tell this thing, I mean, without having a break. Your way of talking will give a, you are really confident and you understand the matter. And basically, since it is colored compound, so we need to measure that color. So the instrument which measures the color is a colorimeter. So the color of the solution is measured colorimetrically at 500 nanometer. So we require a specific wavelength for a specific color. You can write the color of the solution is measured at 500 nanometer using a colorimeter or by a colorimeter. That will be sufficient. So colorimetrically means that we are using it colorimeter, using a colorimeter. If it is spectrophotometrically, then we are using a spectrophotometer. Okay. Now to do this test, what you do, this second part is also important. Now you have to take 3 tubes. One is, write down this thing. This you will do it. I will demonstrate today, and all these things which I will discuss today, I will demonstrate today, and next class you will bring this test. You write down. You label 3 test tubes. First you write down B, that is blank. Second one is S, and third one is T. B means blank. Blank means it doesn't contain anything. It will be having a distilled water. S means standard, means we are having a known standard of glucose based on which we will calculate. In the glucose standard sample, suppose you write down in the blank tube, you take 20 microliter. See, 1 ml means 1000 microliter. Write down. 1 milliliter is equal to 1000 microliter. So we are taking 20 microliter, and that 20 microliter will be taken by a fixed pipette. Pipette at a distance. Pipette at a distance. Bolo. Hemolysis আছে বাস তো ঠিক আছে ওটাও দেখাবো ধরো তো তুমি একটা ইয়ে নিয়ে এসো তো টেস্ট টিউব দাও একটা পিপেট নিয়ে এসো তো পিপেট ওই ছোট টেস্ট টিউব না প্লাস্টিকের টেস্ট টিউব দাও আচ্ছা প্লাস্টিক টেস্ট টিউব না প্লাস্টিক টেস্ট টিউব আছে আচ্ছা আচ্ছা তুমি ইয়ে দিয়ে যাও তো একটা ওই যে হ্যাঁ মাইক্রো পিপেটটা দিয়ে যাও 20 microliter 1000 microliter দুটোই দিয়ে যাও. So you have seen the micro pipette, it was given in the spotter. So there is a 20 microliter fixed pipette, I will show it to you, and there will be 1000 microliter pipette. Using that 20 microliter micro pipette, you will dispense 20 microliter of blank, and do not try to mix that pipette, that Eppendorf micro pipette with the another one, the dedicated one, this is. And similarly for standard, you will dedicated micro pipette. Do not suck and then do not use this one, then it will be contamination. And there will be another micro pipette which will be for sample. And in the blank tube, you just see that you are taking only 20 microliter. But rest, you are not taking anything. So this is 20 microliter. Can you see? Can you see the 20 microliter? And this is 1000 microliter. So there will be dedicated tubes I have given deliberately so that you don't confuse, because if you suck extra amount, there will be touching. And your friends next to your experiment, if you want to use to that one, that will be contaminated and it will show a color. So by you have done this experiment and have left it, but don't think that your train must get a lower marks or false result because of your mistake. So in the standard tube, only 20 microliter, nothing. In the sample, means you will be giving, provided an artificial sample. Real sample we are not giving because that will be infectious material. I tried to use yesterday's sample, but since this was kept in the fridge, there is hemolysis, and show you in the practical class itself. You will see what happens if someone keeps in the fridge. So glucose reagent will be having that thing, that glucose oxidase, peroxidase, and a buffer. That is a ready-made solution. And with the 1000 microliter pipette, that is 1 ml pipette, this is 1 ml pipette directly, you dispense 1 ml and then mix well, so that 10 microliter, 20 microliter gets mixed well with the 1 ml of reagent, and keep it standing in the test tube for 30 minutes at room temperature. And then take the reading at 500 nanometer. And you will see during that 30 minutes by the color changes. Colors change, I mean, since the reaction will take place over time, so maximum color will be developed by at 30 minutes. That is the reason why we take the reading at 30 minutes, because the enzyme substrates will be converted fully to product, into product. That's the basic application. Now you are coming to the real application of enzymes. And today what we will be doing basically an enzyme substrate reaction. Okay. So then you have to do the calculation. Oh, just I am putting it off for the time being. Just 1 minute. I will show you how to calculate. Now, if for the test you will get a reading. For the blank you will get a reading. See that what you have seen. I have shown it to you yesterday. That exactly. This 20 microliter, 20 microliter, 20 microliter, 2 ml. What is written 1 ml? I think I wrote it wrongly. So please rectify. Please rectify. It is because I have to increase that. That is 2 ml, not 1 ml. Sorry. I committed a mistake. But hardly I have written. I apologize. That will be 2 ml. That is 2 ml. You just write down 20 microliter, 2 ml. Yeah. হ্যাঁ প্রজেক্টরটা এটা দেখা যাচ্ছে না আচ্ছা প্রজেক্ট অফ করলে একটু অসুবিধা হবে তাহলে এটা পরে লাস্টে বলছি লাস্ট অ্যাট দ্য এন্ড ওকে দ্যাট উইল বি বেটার বিকজ আই এম ইন কন্টিনিউটি আই উইল এক্সপ্লেন ইট ইন এ লিটল বিট I will explain the calculation, leave some space. Now rest of the things we will discuss. Just to save time, I am doing this thing because this part I have written, hurriedly I have written. Actually this is 1 ml, but since that will be 10 microliter, but you will commit error, that's why I have made it 20 microliter, nothing more than that. Now this will be collected from the blood. So you have to collect the blood. Blood needs to be collected by you. And you have to practice it. Why? Because, see, you will be the overall in charge, technician will fail, nurses will fail at times. At that time will be called. But all of you are Bengali? Is there anybody who is non-Bengali? Anybody non-Bengali, please raise your hand so that I will not speak in, because see, it's an area where most of the people are Bengalis. Don't feel if any one of you is a non-Bengali or cannot understand, there is no need. See, this is a group discussion, small group discussion. We want everybody to understand. The problem which we will face that in a setup, normally this is done, you advised for blood glucose estimation or any investigation, in the ward, nursing staff will draw the blood, or probably in a big setup, laboratory personnel will come and draw the blood. And in the laboratory setup, you are the laboratory in charge, they will bring the and collecting the blood, and then at times they will fail. So unless you practice, you will also miserably fail. And as a doctor, you must learn IM, IV techniques, because some of your near and dear ones in your family might fall sick. You know the treatment, but since you cannot give an IV injection, you will really feel very bad. And your position in that family or in that society and that place will be very bad. That is the reason why I started practicing, learning all these techniques from third year itself. I used to go to the laboratory, I used to beg that I want to learn this technique. In the ward, I approached the sister and then started the IV lines also. So in the third year itself, believe me, all the minor surgical procedures which are done at the peripheral health center level were learned by me. I started assisting from operations also from third year. So that is a learning curve. So in the department which I headed for 31 long years, there were problems. Technicians who are drawing blood, difficult, sir, আমি পাচ্ছি না, sir, bloodটা পাওয়া যাচ্ছে না. Then I had to come and draw the blood. Since you are having an adequate knowledge of medical information about the surface veins also, you will be able to draw the blood. The real problematic situation will be infants, aged persons, those who have undergone chemotherapy, because the veins will be visible. But if you prick the needle, needle will remain inside, but no blood will come out. Similarly, if an IV fluid is given in the channel in the ward itself, the veins have been used, the medications have passed through the veins, and even if you prick, blood will not come. So at that time, you will be called. Now you have to use your own brain, and you have to select in a given patient. Suppose in a cancer patient, I have faced two situations in my laboratory. Apart from daily small veins which they could not puncture, I punctured using some of the techniques which I will tell you. The cancer patient underwent chemotherapy in all his forearm veins. She was a lady, a little bit fatty lady. Blood could not be collected. I asked her to sit down on the table with a height so that legs keep hanging. I sat down at the floor and drew the sample from great saphenous vein present on the surface. I punctured from here. I tightened with a tourniquet here and got this thing. And similarly, from a child, there is a problem. They could not draw the blood. I told her mother to hold down the head, keeping her head at the end of in a bench, and simply pinched. The baby started crying, and I punctured a needle on the neck veins. So that is the reason the sister will not do that thing, neither the laboratory staff. So you have to learn at times from where in a given situation you can draw the blood. So normally materials required for the blood is tourniquet. Tourniquet is this one. The rubber guard, you can use a band type of thing also. So that is required. So sterile syringe with needle. So that is a sterile syringe with needle inside. Some are available without needle also. Needle can be purchased separately. 2 ml blood is just used for drawing blood. It will be usually 23 gauge needle or 22 gauge needle. But for giving injection, there is this is a larger caliber needle. For giving injection, usually 24 gauge is used or less than 24. That will give a less pain. But here the purpose is to draw the blood, and the blood should come out very smoothly. The larger the bore of the side, the minimum is the time, and the maximum blood can be drawn in a short span of time without causing any hemolysis. But if you want to measure the blood glucose, this will be 2 ml of blood glucose. This is, you need not write all these things, you just listen. That part you have to memorize in the first slide. This is for your advanced information. I will not get any chance to teach you, that's why I am teaching. So glucose only. So from one patient, you will be required to do hematological investigation. You will be required to do microbiological investigation. So single prick, you can draw the blood, some amount of blood, and then distribute. So either depending on the number of investigations, you can either opt for draw 4 ml blood, 6 ml blood, or even 10 ml blood. So that from a single prick, you can draw the blood sample for multiple parameters, which is normally done. 70% alcohol is used as an antiseptic solution, not 100%. Or isopropyl alcohol if you cannot get it. Cotton will be required. This is alcohol, this is cotton. Nowadays, cotton soaked with alcohol is also available, small things that also you can use. Now, blood collection tubes. In our time, we used to do in the small tubes with anticoagulant, even a small glass vials, because that was not at that time these type of commercially available tubes which are in vogue right now everywhere were not available. This you will see it with your own hands in the laboratory. So that blood collection tube will be used. These are called vacuoteners. So this gray vacuotener is basically for fluoride vial. Remember, this part you must write down that for blood glucose estimation, fluoride vials are used. Fluoride test tubes or fluoride vials are used. Why sodium fluoride vials? Because sodium fluoride inhibits enolase and thereby it prevents glycolysis of the packed cells like RBC mostly, WBC and also platelets, because if enolase enzyme is inhibited, then the whole glycolytic pathway will be inhibited. So glucose present in the sample will remain stable. It remains stable for 24 hours. Because why this vial is required? It can be from a clotted blood, it can be from a serum also. But if you allow the blood to remain with the clot or with the formed cells, the cells will draw glucose from that plasma. So there will be gradual fall of blood glucose, and in our laboratory I have seen the degree of fall at room temperature usually ranges from 5 mg, usually on an average 5 mg per hour. So if you draw a sample in the fluoride vial, if you draw the same sample in the EDTA, EDTA will not allow clotting also, that is an anticoagulant. And if you estimate blood glucose here, suppose if it is 100 mg per deciliter, and after 3 to 4 hours if you measure in the EDTA vial, the level will be around somewhere around 85 to 80. So that degree of fall will be there. So it can be measured with the EDTA, it can be measured with serum also, but the degree of fall will be there. And in situations, you may be required to do that estimation, but at that time you inquire at what time the blood was drawn and when you are separating it from the clot. Once you separate the serum, then there will be no fall. But so long it remains in the contact with the blood cells, it will draw blood. It will lower the blood glucose level. That is the reason why sodium fluoride is used. Is it clear? Because in most of the setup, the blood is drawn in one place. It is transported to the laboratory. Earliest time you will get the centrifugation, separation, all these things, it will be taking about 1 hour time or 2 hours time. At times, if it is sent to higher level centers, suppose Kolkata, from Bolpur, the sample is being sent to Kolkata. So that will take about 6, 7, 8 hours, even 10 hours time. So that time blood sugar level will fall. But because if you take that fluoride vial, then blood sugar level will not fall. Okay. And band-aid is an optional. Band-aid you require it. Some people give a band-aid. Now coming to the actual picture, this you just understand. No need to write down. You will know all these things. I will not get an opportunity. That is the reason I am telling you. So syringes are available in multiple forms. So this is 2 ml syringe. I am not advertising Dispovan. There is no intention. Multiple companies are producing this type of syringes. But I got this picture from the internet. Immediately I downloaded the picture, and yesterday it was not shown. I thought that it would be better if I show this thing. So 2 ml syringe is available. This is only if you want the blood glucose level, they would use 2 ml syringe. If you want more than 2 ml at a time, then use 5 ml tube. Can you see this is 3 ml tubes are also available? Syringe. So 5 ml is also available, 10 ml is also available. And for babies, usually there's less blood is required, for which you draw this insulin syringe. That is 1 ml syringe. And the needle is very small. At times this syringe also I used for the adult. those whose vein could not be seen, particularly fatty ladies. You cannot see, only surface veins are available. They are just like babies. So I used to use this thing or the needle which used to be when I used in the pediatrics department. I brought that type of needles also, then I used it for those difficult veins. So one thing I want to see, if you see the needle very closely, the needle will not appear just like the needle which you use for the sewing purposes. If you look at the closer end, that will be there. The surface will be like this. One part will not be. It will. Can you see this? Can you get the difference? This part I have enlarged it. So this is called the bevel end. That part must be kept upwards while picking. That you must remember. So as I told you, it is available in several forms. Lower the gauge, higher the diameter. Means if you see the caliber of 24 gauge outer diameter, it is 1.83 millimeter, and 27 it is 0.42. So lower the gauge, higher the diameter, and vice versa. So normally for blood collection we use 23 gauge or 24 gauge. This 21 gauge is also can be drawn, 23 gauge. For giving injection 24, 25 because pain will be less. And needle gauge is a 14 gauge, rapid for blood transfusion, 18 gauge. For blood transfusion again 20 gauge, again mostly fluid IV in transfusion. Slower medication, this 22 gauge because in the vein it will be given, so vein must not be blocked. 24 gauge needle is the 23 gauge needle is commonest needle used in the laboratory. 24 gauge needle is used for the elderly, pediatrics and small veins, and 26 gauge is basically for the neonates and pediatrics department. This is used. This you will know because I have wanted to give some amount of idea, practical information. So blood collection procedure. This I will demonstrate. Yesterday I have given from one patient, one person must volunteer. I will show you the difference. So as a doctor you must know, just to save time, I am telling you this, note down, try to remember all these points. Select a visible vein on the forearm. Why forearm? Because the pain in this area is less. The more you go from this area, middle area, there will be more pain. And in these veins are very much visible. Veins are very much visible here. But if you prick it, this area is very sensitive and the patient will simply start shouting. So avoid pricking these veins from the hand. Not only this thing, the skin is loose here, so veins will slip. So that part is, forearm is the most preferred side. Now apply a tourniquet, which I will be demonstrating. After apply in the middle of the forearm, this upper arm, and then ask the patient to tighten the fist. Basically, we are allowing a more venous return and we are obstructing the blood flow here. Sterilize the area with cotton soaked with 70% alcohol. Do not cross talk. Is there anything important? Hello? What is the problem? What is the problem? Tourniquet, I apply tourniquet, that's what I am telling you. I will demonstrate it to you. Just to save time, I am just giving you a brief idea so that yesterday I spent a lot of time on this. That's why I am giving an idea. I will demonstrate it. Apply tourniquet means you just tighten it. Or I am tightening you. Just come here. So apply tourniquet means you can left hand will be the preferred hand because this is a non-working hand. So you just use this thing, make a like this so that you can remove it. Okay? Ask the patient to tighten your fist. So tightening will cause, greater venous return from this part and also this vein which is draining from this part periphery to the heart will also be blocked because you have applied an tourniquet, and on top of which is allowing you to tighten it. So veins will be permanent, that is your purpose, and from that you will get the blood very easily. Okay, we are trying to inflate that vein which is present here. Normally it is not visible, even if it is visible, but it will remain in the collapsed condition. We are allowing that collapsing condition to bulge it, and she will feel pain, some amount of pain. Now you ask you inflict this thing. I will demonstrate it to you. That now after this thing, some of you should you just come here. You will also volunteer. So একটু তুলো বা কারো এটা তোমারটা আলগা আছে, তুমি এদিকে আছে তো দেখিয়ে দিচ্ছি তোমাদের কি কি মিস্টেক করে দেখিয়ে দিচ্ছি, সেই মিস্টেকগুলো যেন তোমরা না করবে না। বসো বসো, তুমি বসো, সবাই দেখতে পাচ্ছ না? এখানটা দাঁড়াতো, এই দেখো এখানে দেখো ভেনটা দেখো, বোঝা যাচ্ছে না, ঠিক আছে? দেখতে পাচ্ছ ভেনটা? The vein is not visible here. So you just try to locate where is the good vein. Now vein is not visible here. If it is not available, then you select for the right arm. Now again the vein is not visible here. Vein is there. Vein is there, but vein is not visible. In contrast, তুমি এসো দেখিয়ে দিচ্ছি প্র্যাকটিক্যাল প্রবলেমটা কি আছে। এসে চলেছে রিয়েল প্র্যাকটিক্যাল প্রবলেম, এগুলো হয় ঘটনা, তোমাদের দেখিয়ে দিচ্ছি কি ঘটনাটা ঘটে। তাই বলে কি এর ভেন নাই? ইয়েস, শি ইজ হ্যাভিং ভেন, but she is having a vein deeper to extend. It is not visible. In contrast, if you tighten the fist, now you can see some veins here, but that area I am not going to prick because this will inflict pain. Come here. দাঁড়াও, তুমি এখানে দাঁড়াও। এই দেখো ভেনটা দেখতে পাচ্ছ? Now see what I am doing. দেখো আমি দেখাচ্ছি। এই অবস্থায় যদি ভেনটা করি, if I want to prick it, the vein is relatively in a collapsed condition. What I am doing here, I am putting this tourniquet right here in the upper arm, in the middle. Just see how I am doing this thing. Now I am asking to tighten his fist. Tighten. Can you see the prominence vein? There is no need. Can you see? Okay, you can see. Now once you do this thing, then this cotton will be. I am not pricking you right now. Don't worry. I am not pricking you. See, I am just applying. So that area will be soaked with the cotton, or here you just apply this cotton in this area. But you ask him to tighten his fist. Allow the spirit to dry completely. This is not done. And once you sterilize the area, you cannot touch it. But most of the times, everywhere, I have seen after this thing, there is a touching, again pricking, again needle I am drawing. All these mistakes I will show it to you. The moment you touch with your hands, again you are decontaminating. I mean contaminating the area. So again, if you want to sterilize this thing, use this again, swab again. So do not do this practice. Do not allow this practice to occur, because this is going to cause some amount of infection, although doesn't occur really, because the minor area is pricked. So once this area is pricked, then you prick it from the side. You can prick directly on the vein, but then the bleeding will be maximum. If you prick it from the side, then there will be little pain, but that blood area will be blocked. So after you insert the needle, you do not ask the patient to release the fist. Once the blood is drawn, then you ask the patient to release the fist. So now the vein is going back, and while keeping this thing, you just remove it with your right hand, because this hand is now closed, because you have punctured it. If you don't do it, blood will come out. And then you just ask the patient to keep the hand flexed and with the fist released. There is a tendency, the patient by reflex will tighten the fist. এই করবে, এই জিনিসটাই করবে। Even if he does this thing, or if the patient does this thing, there will again backflow. Again it will be blood. আর এটা খুলুন না, ও যতবার তুমি খুলতে বলবে ততবার তো বন্ধ করবে। খুলে দিন হাতটা ভাঁজ করে রাখুন, হ্যাঁ, আধ ঘন্টা। দিস উইল বি দ্য ইয়োর টাইম। চুপ করে বসে থাকুন, চুপ করে বসে থাকুন এখানে 5 থেকে 10 মিনিট বসে থাকতে বলবো, আর কোথাও নড়বেন না। কারণটা বলে দিচ্ছি। এরপরে কি করবে, এরপরে যে কোনো করে মিস্টেক, এরপরে এ করবে কি, বেরিয়েই এখানটাকে নিয়ে ঘষবে, ঘষবে, একবার দেখবে রক্ত বেরোচ্ছে, আবার ঘষবে, আবার রক্ত বেরোচ্ছে, আবার ঘষবে। এটি করা যাবে না। কারণ বলছি, আমরা যখন ইঞ্জেকশন, when we give injection, we are introducing an injection to the site, and there is a temporary swelling, and in that injection area what we do, basically we squeeze this area to allow the spreading of that injected material. The purpose is totally different, so that there is no tension build up in that particular area, so there will be less pain. That is not true here. Here we have punctured the area, and we have to give time to allow the normal system to clog that area. There will be platelet aggregation, clotting factors will be activated, and that punctured area will be sealed. Now this punctured area has been sealed naturally in 5 minutes time. Again you are dislodging. Again you are checking. Again the system is trying. Again you are doing this thing. Ultimately, at one point of time, the clot will come out, and the blood will extravasate from this blood vessel into the extravascular space, and there will be swelling. And people are really restless. They don't want to keep the hand flexed for 5 minutes, and after some time, they will come with the swelling. ডাক্তারবাবু, এই তো আমার হাতটা ফুলে গেল, রক্ত নিল। কি করে রক্ত নিল? সে যে এতবার ঘষেছে, that he has done that several times, he will not admit. And you have to be careful. Immediately ask the person, how many times you have rubbed it? He is not at fault. He or she is not at fault. That's why what I have written on the right hand side, after giving blood, release your fist, release it keep it for 5 minutes. If you do not try to ever rub your area, otherwise there will be bleeding. All these things were written, and I have used this in multiple areas. So while they are entering into the laboratory, that is seen. While they are giving blood, that is also seen. Then after some time, if the patient comes, I used to tell, were you sleeping at that time? In multiple places, and I have instructed you, the technicians have been instructed. But this is a problem. So that area, these technicians make an area by touching the needle also. And there will be, after sterilizing the area, again there will be touching. That is not allowed. Okay. Now, some of the tips I am telling you, some of the things I am going to tell, because now recording is not going on. See, to learn medicine is a science. There is no doubt about it. This part, selection of vein, puncturing vein, all these things are real science. But to practice medicine is an art. So most of the successful doctors are not only confident about having a confident knowledge on the science, but they are also having mastery on arts. So while you are picking the patient, obviously that cannot be a pleasurable one. That is painful. And you have to, recording your purpose is to give less pain. If you give the less pain, the patient will say that doctor collects the blood very good, or even the technician collects the blood very good. I want to give the blood to be drawn by that particular technician or by the doctor. There are 2 tips I am telling you. Purchase a costly syringe or needle. That costly syringe or needle is just like blade. The needle will be very sharp, and sharp needles usually give less pain. That is number 1 point. Number 2 point, while you are drawing the blood, you try to inflict as much pain as possible within the entire forehand, so that there will be minimum sensation of pricking. So you ask the patient, you know that blood, this vein is visible, even if the patient doesn't tighten also, I can draw the blood in this condition itself. Even he is standing, without using this to indicate from this vein, I will be able to draw the blood. Now just to avoid the pricking, what measure he will do, he will take, You'll ask the patient to tighten and then ask the patient to release the fist. Tighten your fist, tighten your fist, tighten your fist, tighten. Go on tightening. So tightening will give more pain. And at the height of that pain, you have to prick it. And during this pricking, you divert the patient. What is your name? What is your house? What is distance? All irrelevant questions. Irrelevant to you, relevant to him, but beneficial to you because that person will be, that's আমার বাড়ি ওখানে মুর্শিদাবাদ বাড়ি আচ্ছা আচ্ছা এটা ভরপুর বাস স্ট্যান্ডে কত যেটা কোন কোন বাসে যায় কতক্ষণ সময় লাগে এই হিজিবিজি কোশ্চেন করো ডাইভার্ট করে দাও ডাইভার্ট বাই দ্য টাইম ও ওইসব আনসার দিতে তোমার ব্লাড টানা হয়ে গেছে ব্লাড টানা হলে হ্যাঁ ঠিক আছে একদিন যাবো খুব ভালো আছে বুঝলেন আমার ইচ্ছা বেড়ানোর ইচ্ছা আছে বলে সিটে টেনে নিয়ে আচ্ছা ওইখান থেকে যাবো কতটা দূর আছে বলে দেখি তোমার সব টানা হয়ে গেছে ব্লাড বাই দিস টাইম ভুলে গেল ঠিক আছে দিস আর দ্য আর্ট ইউ হ্যাভ টু অ্যাপ্লাই অন এ গিভেন সিচুয়েশন চলো যাই আর কি আছে বলতো ও এইটা তো টাইট করিনি সো এইটা মানে তোমার why I am telling you because you just want practicing because without practice you will never be able to succeed particularly difficult events what I can suggest you can purchase a box of syringes and needles and this is a low cost instrument you can prick each other hardly matters what is the problem because you can prick 2 to 3% at a time you just play see patient will not give this is a private institution I am telling you government institutional setups are different but you have to learn the only learning way to help from each other from you I studied in a government college there is no problem but in a private setup it is not allowed you will not be given a chance so you have to find your own out you just at your odd time even after you pass I suggest you go for voluntarily to some government hospital work for some hours to learn these techniques they will allow you that I want to draw this blood I want to learn this IV techniques they will allow it so I told you so apply tourniquet ask the patient to tighten the fist this part I have covered sterilize the area with the cotton sock with 70% alcohol okay just rectify with allow the alcohol to dry I repeat open the syringe from the plastic holder tighten the needle that you must ensure also that it is tightened otherwise there will be leaking from that side this you will show I demonstrate pick the side with the beveled side of the needle upwards that beveled side I show you that side should be upwards not below gradually draw the blood because if you draw the blood rapidly there will be a high amount of turbulence to the needle and it will cause a rupture of the RBC membrane and the serum you will see it will be hemolyzed. Ask the patient to release the fist. After keeping the alcohol soaked cotton, remove the needle gradually. Ask the patient flex continuously for 5 minutes. Hand flex for continuously. No rubbing on the area. Less movement of the punctured hand for 30 minutes because that area has been punctured, that area has been sealed, some more time will be given so that it is completely sealed up. Somewhere this band-aid is applied as a cosmetic value but this you may not require it. Now after you have collected the blood, you have to centrifuge the blood to get that sample that I will demonstrate to you. And then from that plasma you will get the estimate of the blood. Now problems, this will be the problem in the situation. First apprehension, pricking nobody likes. So there will be some apprehension and the degree of apprehension varies. Second, pain. So I have given you some idea how to reduce pain and you have to do it masterly and in your own ways. Now bleeding from the site. If you rub it, there will be bleeding. And particularly for aged persons, whose veins are atherosclerosis means hard, their bleeding will not stop even after 10 minutes. Number one. Number two, many patients are on anticoagulant therapy because they are taking anticoagulant drugs to keep the blood liquid, particularly cardiac patients. For them, you ask them to keep the hand flex for 20 minutes to 30 minutes. Because from that side, bleeding will not stop. Because their platelets are all loosely attached. They have been kept loosely attached by the drug. So you have to give enough time. And in that patient, I asked, do not use the hand for another 2 to 3 hours. Swelling around the pricking site, I told you, if you, by mistake, if you cause any extravasation of blood, that is your fault. If the patient does it, that is patient's fault. Vasovagal attack, common problem. Sometimes people are seeing somebody is being pricked, blood is being drawn, just by seeing while in the queue, patient will faint. And it happened yesterday. I am not blaming, it can happen with anybody. Why this happens? Because he is having an empathy. We all know sympathy. Sympathy means, all of you know what does sympathy mean. The opposite word is cruel. But in these patients who have vasovagal attack, those who have been pricked, they can suffer because they are having the pain, they are seeing the blood. Patient can have the vasovagal attack itself while blood is being drawn, or soon after blood has been drawn, or just by looking at the site, somebody else can suffer from vasovagal attack because they are having empathy. Means they are having the same feeling of pain within themselves. That he is being pricked, at least as if I have been pricked, as if I am feeling the pain. And I do not know, I have heard that Thakur Anukul Chandra became famous because a horse was whipped and the whipping mark was found on the back of Thakur Anukul Chandra, but I am not sure about that story. That is an extreme form of auto-stigmatization or empathy or hyper-empathy. So degree, if it is varies too much, he might fall right on the site or maybe afterwards. So vasovagal attack can occur. So vasovagal attack will occur because there will be extensive peripheral vasodilatation. Blood will be drawn on the lower part of the body and brain will suffer from ischemia. And because of that thing, the patient will fall down. And this is very much important, particularly for pregnant ladies, those who have come for advanced pregnancy. If by chance while it falls, a high chance of bleeding and loss of baby also. So that part you have to ensure. So better you draw the blood in a situation on this type of aged person where lying down position is available, so that immediately you can allow the patient to lie down. The management of vasovagal attack has to be done by you. Do not try to give water on the face. All these things, all are nonsense. Simply raise both the legs together so that by gravity blood will come down from the leg and it will be horizontally passing through this body and it will come to the head. Then heart will start pumping. And immediately ask somebody to raise the hand, both the legs in a second's time, and put your hand on the pulse. Usually pulse is not palpable. That means heart has been stopped. Heart has stopped. And if you allow it to continue for some time, you can see the consequences. You know the consequences. So then if the pulse comes, keep the legs raised. Or if the pulse doesn't come in another 10, 20 seconds, 15 seconds, give a cardiac massage. Some amount of cardiac massage. That I had to apply yesterday. The pulse will come. Then once the pulse is stable, keep the legs removed from the upright position to the horizontal position. Allow the patient to lie down at least for 1 minute. Let the system regularize. Then ask the patient to sit down on the floor itself and on a support, preferably on a support. After that, through that support, you ask her to stand up simply like this. And you remain on the front side because during this thing, again, you might get an attack. Because all the vascular system may not be correct. Some amount of peripheral fluid will be there. And once he is stable, you just accompany him, so walking for some distance. Then you allow him or her to move on. So that management you have to do. So yesterday what happened? While she was on the floor itself, I wanted to bring one chair from HOD's room. By that time, she was too smart to walk, and immediately I allowed her to lie down, because even before entering the lab, she would have collapsed, because she has not recovered completely. So this can happen anywhere. You have to manage this thing. So empathy, hyper-empathy, that is another issue. Sympathy, auto-stigmatization. Seeing somebody's pain, somebody will feel it, internalize that pain, and he may suffer also from vasovagal attack. So with this thing, I am concluding. I will show it to you. Write down. You just go. You come to the laboratory. Give the set completely. Set what is written there. I will explain it to you. ফ্রিজে রেখে দিয়েছিল, ব্লাডটা আমি ভাবলাম তোমাদের সেরামটা দেখাবো, সেরামটা দিয়ে তোমাদের টেস্টিং করাবো, সেটা করতে পারলে ব্লাডটা হিমোলাইসিস করে গেছে। দেখতে পাচ্ছি হিমোলাইসিস করলে সেরামটা কিরকম কালার আছে, দেখতে পাচ্ছ কালারটা দেখতে পাচ্ছ, একদম রক্ত, মানে পুরো আরবিসিটা ফ্রিজে রেখে দিলে পুরো আরবিসিটা রাপচার করে গেছে। এটা আজকে রুম টেম্পারেচার রাখবো, তাহলে তোমাদের পরের দিনে যে করবে, পরের দিন তোমাদের আজকে কি ব্যাচটা আজকে তোমাদের। So these are the three types of vials. I will discuss in detail in the next class as you raise this issue. Just to save time, I am telling you, this grey colored tube is for blood glucose. This is for EDTA, and this is for clot, that is plain vial. It can be used in the plain vial. Clot activator is given to hasten the clotting time, so that instead of 2 hours, it can be centrifuged in half an hour time. And this I will show it to you. Just to save time, I am drawing this thing. So I will draw basically 6 ml of blood. I will give 2 ml in each test tube and allow it to stand, and meanwhile I will demonstrate this thing. After that I will centrifuge and show the sample how the plasma looks like. For lying down on a bed, lying down on a floor, it doesn't look nice. In that case, worst case, you just keep a sadran, just some the polythene sit like that, so that the patient will fall down. The best thing is to manage this thing at the ground level, but at your level you will be wearing a pant. I mean, for you to sit down, it will be difficult. That is a problem, nothing more than that. And all are not accustomed to sit on that position and to treat on that position. That is the reason why it will be kept on the bed. And if it is a reclining position, then the patient can be reclined back, so there will be no problem. You can raise the legs up. I will demonstrate it, the vasovagal attack, soon after drawing the blood. Now again, just sit down, I am not wasting time, I am just picking, because yesterday while picking, there is accidental mistake by me, and accidentally there will be extravasation. দেখো এখানে দেখলাম কি করছি, দেখো now observe what I am doing, and you have to do this thing, you will practice it. I am টাইট করলাম, টাইট করো, মুখটা টাইট করো, মুখটা টাইট করো। এখন তোমরা জেনে গেছো, এখন ওকে ডাইভার্ট করা যাবে না খুব বেশি, কারণ আমি ডাইভার্টার ওইটা শিখিয়ে দিলাম, ঠিক আছে দিলাম, ঠিক আছে। তবু আমি বলে দিচ্ছি, জাস্ট হোয়াট ইউ উইল ডু। আচ্ছা একটু স্পিড কটা নিয়েছে না, স্পিড কটা নিয়েছে না, এটা নোংরা, স্পিড কটাটা নিয়েছে না ওখানে। এটা ব্লাডটা টানার পর না কি করবে দেখো, বলেছি কিভাবে ডাইভার্সন করে। ডোন্ট quarrel. In the summer there will be usually dirt. আরে বাড়িটা কি করে রেখেছেন নোংরা করে, এখানে দেখে তাকার এদিকে, দিস ইজ ডাইভার্সন। এগেন পরিষ্কার করতে পারে না সাবান দিয়ে, দেখে তাকার ময়লাটা কতদিন হয়ে যায়, ইনফেকশন ছাড়বে, এই হচ্ছে ডাইভার্সনের তোমার রাস্তা, ঠিক আছে। এরপর তুমি চট করে ওটাকে ফেলে দেবে, যদি খুব বেশি ময়লা থাকে তখন এটা ফেলে দিয়ে তখন দ্বিতীয়বার করবে। ধরো মুঠোটা করো, ওকে এই হাতটা ধরতে বলবো, আপনি এই হাতটা এইভাবে ধরুন, এটাকে এইভাবে ধরুন, এটা ধরুন, হ্যাঁ এইভাবে ধরুন। দেখো বিভেল এন্ড আই এম পিকিং from the side. এই দেখো ব্লাড চলে এসছে, দেখেছো, এই দেখো ব্লাড চলে এসছে। টাইট করে থাকো, টাইট করে থাকো, ওকে ডাইভার্সন করাও, ডাইভার্সন করো, ডাইভার্সন করো, ওকে ডাইভার্সন করো।
আঙুলে বলছি, আঙুলে তুলে হচ্ছে ফিঙ্গারপ্রিন্টে কোথায় ডটটা আছে দেখ, দেখ ডট কোথায় আছে।
এই দেখছো কম, মুড়িটা খোলো, মুড়িটা খোলো, মুড়িটা খোলো। ভাঁজ করে রাখো, ভাঁজ চিপে ভাঁজ। বাস বাস, থাক থাক থাক, তুমি আর কিছু করো না এখন। আচ্ছা চলো। এই নিডলটা সরুর জন্য দেখো ব্লাডটা এখানে এলো না কম তাড়াতাড়ি, দেখো ওকে পেনটা কম দেওয়ার জন্য নিডলটা আমি ইউজ করেছি, কিন্তু ওই পেনটা একটুখানি প্রিক করেছে, এক্সট্রা হয়েছে এটা ঘটনা, কারণ এতক্ষণ ধরে টেনেছি না, টাইমটা লেগেছে। এই নিডলটা যদি ইউজ করতাম বেশি, তাহলে কিন্তু ওর ব্লাডটা চলে আসতো খুব তাড়াতাড়ি। So this is the reason this is a 24 gauge needle. This is the problem with 24 gauge needle. It should not be used. We want some amount of blood, and there should not be any function. In that area is slightly, I have shown some extraction has taken place. 23 gauge needle will be a good. This will be for 22 gauge needle will be better for this one, because he is having a very good blood vein. The caliber of the vein is higher, so that rapid even 22 gauge needle you can use it. 23 gauge needle will give a faster, 22, 23 somewhere in middle. So there will be less pain also, you have to compromise. So 23 gauge needle will be mostly used, preferred use. But this, let me do this thing. See, when a smaller caliber needle, use a larger caliber needle to dispense, because there is a vacuum in it. That is the reason why it is called vacuum. The blood, if I prick it, that normally due to vacuum, blood will be sucked. Now in this case, the blood is not sucking, because either there is a problem in the vacuum itself, or because the needle has been blunted, that opening small area, so we have to give the blood slightly dropwise. So because of the less volume of the blood, I am giving only the two samples, one in this one, and one is clotted, I am giving it. See, this is the problem of, pressing. If there would have been, there is no, this is not, sucked, because again the caliber of the needle, because if you draw the blood in the low caliber needle, use one high caliber needle so that the blood is sucked properly. This is not the way the blood has to be given. Still I am giving it, and this will be given very slowly. This is the problem, a real life problem I have shown it to you. This ought not to be done, because normally this is sucked normally by this thing. And 23rd gauge needle, we don't have any problem. Now once this is anticoagulant is there, you mix it properly, because this is a chloride thing, mix it. And this is an anticoagulant, this is also there, but you just stir only once or twice. Now the clot activator is there, it will hasten the clot. After some time we will see this, after some time we will draw this blood. See, less amount of blood has been given. I am not using this one, next day I will show it to you. Okay? Clot activator has been given because it will hasten the process. Otherwise, it will take 2 hours time. In half an hour, you will get the clot. I will show it to you. This I am keeping it reserved for you. I will do this test. Let us করব না। করো প্রোটোকলটা বার করো। তুমি খাতাতে লেখো না? Then S. Then T. Okay? এটা করার পরে এক কাজ করো, মিডলে এখানে মিডল রোতে নিয়ে নেবে, ঠিক আছে? কারণটা বলছি পরে। না এই দেখো টাইট আছে, তবুও একবার ইচ্ছা করে খুলে একবার টাইট করে নিজে, just tighten it also. Now this is 20 microliter, you fix it, check it. Now in the test tube, you just first you keep this thing in with your hand, okay? Now you tight, see, gradually draw. There should, either you should stop shouting or come here. See, this is, you draw it very casually, very carefully, slowly, so that there is no bubble inside. And then you just dispense it once, okay? Now again you just draw this sample, you just insert this thing, look at this, how I am doing this thing. I am putting this tip a little inside and then drawing this thing gradually. And at the end, there is no bubble inside. So that needs a practice. Now I am taking this thing exactly, going down into the test tube and dispensing. The last drop, you just touch a little bit on the side. Okay, if it doesn't fall. This is 100 milligram, you just see it with your own eyes. This is 100 milligram per deciliter standard solution. So mix it a little bit. There is no problem even if you do not mix, but it is in the solution. Again here you just do the same practice. You just always keep the cap upwards. Again you tighten. You check this thing and tighten it once again. And then you draw this sample from here. You just again you have to look it down. Now you have to check whether there is no bubble or not. Again you dispense it, or if there is no bubble, there is no problem. Also you give. Now if you make any error here, then that will be problematic. And you will see that all of you are not sucking properly because reading will not be the same. If the reading are same, then there is perfect matching. So now you are dispensing it again, just similarly, exactly in the same way, completely putting it here. And this keeping this thing as such, capping it. Now going to, this is third one, new one. This is this one. This is blood test sample. Again I am doing, see, hold it little like this. During examination what happens? Your hands are trembling. Then in that case you just lie down here, sit down here. This will be the position. Because out of fear psychosis your hands might tremble and you can feel the entire thing. That will be disastrous consequences, so practice it. So when you are in a hurry, your hands are trembling, you just sit down here closely and then you just, it will be like this. You keep your eyes level down below, there is a bubble. So if there is a bubble, what you can do? You can simply just drag it like this. So it will come down. So then you plunge it, press it directly, so that if there is any material, it will come down. Now suppose you are in an examination setup, you just do this thing. See, there is no bubble. So once you are confident, then at that time you can do this thing. But usually there are some of the patients, some of you might be really shaky and might suffer problems trembling also. So we are dispensing like this. We have dispensed. We have all done this thing. Now we are bringing all these things together in the front row. Twice. This test. So again the same procedure. You just check it, recheck it. This 1000 microliter, you just check it. There is no problem. And again you tighten it. Tighten it properly. Now you just shake it up and down. Again, in this case, you have to draw. There is no bubble, and you have to practice it. Okay. Now, if I dispense, I am showing it to you. Now, if I dispense, that just see, this is the way I am dispensing. So there is no problem. Again, I am sucking, dipping it down. You can go down, touch the lower end, and then pull your pipette a little up. Gradually you do this thing. Is there any bubble? No, there is no bubble. Now I am giving it to you, this thing. This one I am giving on the little on the above, because the sample, it must not touch the sample. So gradually do this thing, because if you do not do it slowly, then that solution that it is containing glucose, it will be simply mixed with this thing and it will contaminate the reagents. Now if there is a bubble, you just press it down. So this part is also clear. Now you put it here. There is one thing deliberately I wanted to see. Again, you see the moment you check, you just dispense it. This you have to do a little faster because time has to be almost same. দেখো পিঙ্ক কালার চলে এসছে অলরেডি, দেখতে পাচ্ছ পিঙ্ক কালার দেখতে পাচ্ছ, আস্তে আস্তে দেখতে পাচ্ছ, একটু সময় দাও, তাহলে তা কোথাও চলে আসবে আস্তে আস্তে। ততক্ষণ আমরা এটা করে দিই, ক্যালকুলেশনটা বুঝিয়ে দিই, খাতাতে লেখো তো, কনসেন্ট্রেশন অফ দ্য টেস্ট লেখো, তারপর ইয়েটা বোঝাচ্ছি, তারপরে আমি এইটা বোঝাচ্ছি, খানিকটা ইন্টেন্সিটি অফ দ্য কালারটা দেখেছো, সমান ইকুয়ালি লেখো। ফার্স্ট লেখো সেট দ্য মেশিন টু 0 with distilled water. Set the machine to 0 with distilled water. Of test, OD means absorbance. OD of test minus OD of blank. Fear psychosis. Basically, the pain of that particular person from whom the blood is being drawn, or somebody he is seeing or looking at that site, he is empathizing for that pain being inflicted on others due to needle puncture. Because of the hypersensitive reaction, patient will empathize her feelings into, or his feelings into his or her own, and will reflect in his own body. Because of the fear thing, fear psychosis, there will be severe vasodilatation. And because of the severe vasodilatation, because sympathetic tone will be decreased, and that will cause peripheral pooling of blood. So the amount of blood which is normally circulating in the blood normally, even if you walk or run, because of the vasoconstriction, the blood doesn't allow to be completely away from the cerebral circulation, upper part of the body. Then remains functioning even if you play football. Now, in that particular situation, the peripheral vessels will be dilated. So the tone of the peripheral vessels will be lost. So blood will be basically pulled down due to gravity downwards. So there will be no blood to the brain. So brain will suffer from ischemia, less supply of blood, even actually full ischemia. And because of the full ischemia, patient will faint, suffer from unconsciousness, and he or she will simply fall on the ground. And during this process, he might sustain a head injury depending on the height from where he is falling, that patient is falling. Or if it is a pregnant lady, you know that disastrous consequences will be there, might be there also. So once the patient has, fallen on the ground, never try to pull up from that patient, from that position itself, ground. In that ground position, when the patient, whatever in position the patient falls, you allow the head side to be on the down and both legs to be up. Why both legs? Because if you raise one leg, only 50% of the blood will get. If you raise both the legs, then the entire blood, this 5 liters blood literally has come down from this part to up to this part. So you are simply lifting it this upward. So the blood present in the legs will be completely down, because now there is no vessel tone. So vessel tone is totally lost. So blood will come down and it will go, move through this thing, and then in the same blood vascular supply will start getting, brain will start getting the blood. And meanwhile, heart will also start pumping. And immediately put your hand on the radial pulse. That radial pulse you must examine very thoroughly. Because in many of your individual, particularly those who are fatty, you will not get pulse properly. And if you do not get in the right hand, check on the left hand immediately, because there might be aberrant radial artery also. This artery may be not present rightly here in that particular individual, unfortunately. Might be. It has passed through this thing, so immediately put this thing. If you do not get a pulse, immediately give a cardiac massage. Because if you give a cardiac massage, you are mechanically stimulating the heart. And because the legs, somebody is raising the legs up, so there is no dearth of blood supply right now. Only thing is that you just pump, allow the heart to pump, because brain is still active. He is not totally, he has not died. So in a short while, this pulse will come, but the volume of the pulse will not be the same as of a normal person. So it will come slowly. The moment it comes slowly, you keep the legs raised till that position. Now once you get a normal volume of pulse, then you allow the leg to be brought down gradually, not abruptly. Gradually down from that height. It is almost vertical. Put the legs vertically up, so that 100% blood is drawn from the legs. Now recline it a little bit, make it obtuse, then make it gradually lower down this thing. Now put it on the horizontal position. Now, once in the horizontal position, again you go on checking the pulse. There might be normal resorption of pulse. There might be irregularity also. Now, if irregularity means everybody's nervous system is not same, particularly this particular patient, because of that situation, only out of 100 or 200, 300%, he has fallen, or that person who is watching has fallen. So his or her system is not that strong as the other people. So that pulse will not be regular. And the more you see the case, the more you will realize that problem. Now, once the pulse is stable, fully, same volume, same rhythm, then you allow the patient to draw, and somebody must, give a support, or even if there is no support, I'll show it in a peripheral situation or in a home situation. You just allow the person to sit down with his hands, with both the hands on the supporting this back, nothing like that. Just put your hands, and you give a support also. So once he is a little bit stable, then you ask to gradually stand up. But again, the system is not stable. Again, if I have seen, even after doing this thing, again there is a vasovagal attack. So then you just lie down and allow it to stand for at least 30 seconds against support, and you stand on the front. By chance, if he falls there, you can simply hold him or her from falling down, and then you accompany a little distance, say 5 meters, walking gradually, and then you release him. And you ask the patient, once he is walking normally, ask them to take a rest of 10 minutes. Because of the fear psychosis, the situation which made him psychologically weak, I am telling you. Just to get that strength, you allow the patient to sit down quietly for 10 minutes. Yes, you are okay, everything in the system is okay, but take 10 minutes rest before you go. Particularly if he is driving a vehicle, motorcycle, scooter, this is a normal common. I am okay now. But you advise, you take some food, move here and there. After half an hour, you drive the vehicle. So don't take that risk. Because you don't know, you will be again having that idea that I have fallen down on the floor. There were several persons who have seen, she might feel shy, he might feel shy. His mental reactions will not be known. He will be thinking while driving that I fell down during this thing. And in the course of this thing, he might sustain an accident. So that is the basic purpose of training you. And remember one thing, these type of things are common, particularly in the pregnant individual, particularly aged, and those who are seeing the blood drawing for the first time, particularly. They have not seen. Once you see or somebody sees it, his brain will be seasoned to it. To those who have this type of problem, the best advice is to allow him or to allow her to handle some amount of blood mixed with his hand, like fish blood or even chicken blood, so that feeling is there. Ask him to prick something. So that part will be there, because you are all medical persons. You have to handle in some way or other. You have to do the operations, and there will be much more cuts, there will be much more bleeding. You have to acclimatize your brain to that extent, so that you yourself do not suffer from any kind of such setback. Patient will come, patient will bleed, you will see patient is bleeding, you will will not be able to control all such things. A torrential bleeding. You might cut an artery accidentally. There will be simply jerk of blood. It will be coming like a syringe. If you just like a holy syringe during holy, we just use this color. It will come out in jets. So that type of situation will happen. So be prepared for that. These are not your area right at this first year student, but I want to train you clinically oriented for right at this level, so that you get really prepared for the clinical years. But do handle such type of cases wherever you get a chance. Otherwise, everywhere, every situation, you will not get a chance. Wherever you get a chance, try to get involved. Try to observe what the others are doing. Okay, try to learn something. And do not overreact, do not try to counsel too much to that particular patient. Only thing is that she should not suffer or he should not suffer in future course of time. Because we already 1 o'clock, although shortage of time, I am just demonstrating you. Okay? So let us go to take the reading. The intensity of color increased. Now I am showing, let us go there. I am showing it to you. Showing? Okay? Okay. Just before that, I will do this exercise. অফ সেন্ট্রিফিউগেশন। চলো ওইদিকে চলো, দেখতে পেয়েছো লিকুইড আছে, এইটা দেখো ক্লটেড নিয়েছি, দেখো উপরের পার্টটা দেখো সেরামটা বেরিয়েছে অল্প একটুখানি। আমরা যদি একটু টাইম দিই তাহলে কিন্তু আরো চলে আসবে। ঠিক আছে, দেখতে পাচ্ছি, দেখো দেখো, হাত দাও, দেখো নাড়াও, ঘোরাও, দেখো ঘোরাও, উল্টাও, টিল্টে করো, দেখো ব্লাডটা ক্লট করে রেখেছে, সেরামটা আসছে। They basically formed cells from the plasma in the suspension. This is in the suspension because RBC, WBC are all suspended in the plasma. Now, what we will do is I'll putting here, and I'm putting in the correspondingly on the opposite side. There are cotton আছে, দাও দেখি, কোনটাতে কটন আছে, এই কোনটা কটন আছে দেখো তো, কোনটাতে কটন আছে, কটন গুলো সরিয়ে দিয়েছো, একটা কটন নিয়ে এসো দূর থেকে, কটন গুলো সরিয়ে দিলে কেন এখান থেকে? আচ্ছা ঠিক আছে, তো কটন ছাড়া তুমি তুলতে পারবে তো? আচ্ছা এই দেখো, এইদিকে দিলাম, ঠিক আছে, একদম অপোজিট সাইডে, বিকজ দিস উইল কাউন্টার ব্যালেন্স, বিকজ ইট উইল বি রোটেটিং ইন আ সিঙ্গেল অ্যাক্সিস। একটা দেখাচ্ছি, এই দেখো, ঠিক আছে, যেই ঘোরাবো না আস্তে আস্তে স্পিডটা এরকম করে, এরকম যেই ঘোরাবো এরকম আস্তে আস্তে হতে, এই যখন ব্যাকসাইড শুরু থাকবে এরকম জায়গা থাকবে। এদিকে এসো, যাও, না তুমি নিজে হাতে করো, না ঠিক আছে, না করো নিজের হাতটা দিয়ে ওইটা করো না, যেটা দিয়েছি এটাতে করো, এরকম করো, দেখো, যাও জাস্ট টাচ অ্যান্ড ফিল, যাও নিজের হাতে দেখো, যত স্পিড বাড়াবো একদম পুরো হরাইজন্টালি জিনিসটা যাবে। যাও সবাই মিলে দেখো, লেংথ আছে, দিস আই হ্যাভ ক্ল্যারিফাইড, দিস ইজ 42 means 420, দিস ইজ 48 means 480, দিস ইজ 520. This ideally should be taken at 505. Since 505 is not available, that I am nearest is 500. That's why I am taking it this one. Is it clear? And now, what you have to do, you have to set it to 0. This will be the there is a mark of white mark. Can you see this mark? And there is also a white mark. And this has to be matched. Here, if you see, there will be resistance. Put it. দেখো যাবে, দেখো এতটা ঢুকছে, ঠিক আছে, এই হলো, দেখো এতটা ঢুকছে, ঠিক আছে, ওকে। Now here what we are doing right now, reading will not be the same. There is a problem in this machine. So you just whatever way you do, you thoroughly clean it outside and look at it. It is transparent and it is clean. There should not be any dirty. Now you put this thing horizontally and tighten it. এটা খুব বেশি টাইট হয়ে গেছে, সাস্টেন প্রেসার দিয়ে করবে। এবার এইটাকে দেখো সেট করবে 0-তে, সেট হয়ে গেছে, ওকে। এবার 0-তে সেট করলাম। এবার আমি এইটাকে জলটাকে এখানে ফেলে দিলাম। জলটাকে ফেলা অবস্থায় কিন্তু এই অবস্থায় ডিকেন করে এই অবস্থায় তুলবে, আর নিচে উল্টাতে যাবে না, উল্টাতে গেলে আবার জলটা চলে যাবে ওদিকে। এবার এখানে নিয়ে এলে তোমার ব্ল্যাঙ্কটা দাও, খাতাটা বার করে যে লিখেছিলে, একটু কাশি হয়ে যাচ্ছে, ফার্স্টে জল দিয়ে 0 করে দিলে, এটা দিয়ে 0 করে দেওয়া যাবে, এটা দিয়ে 0 করে দেওয়া যাবে, ওটা দিয়ে 0 করে দিলে কোনো মাইনাসটা করারই দরকার নেই কিছু। তোমাদের যেহেতু স্ট্যান্ডার্ড টিচিং, আমি তো সব দিন পড়াবো না, দেখো যেটা করলে সেটা এদিকে সরিয়ে দিলে। না দাঁড়াও একটু করো, এটা রিডিংটা নিই। এবার এখানে যখন দিলে আবার এই দিকটা রাখবে, এখানে রেখে এটাকে শক্ত বেশ, জিরোই আসছে। এটা তো ব্ল্যাঙ্কটা দিলাম, ব্ল্যাঙ্কটা 0 করো, লেখো 0, কোনো অসুবিধা নেই। বডি অফ ব্ল্যাঙ্কটা -0 লেখো, -0 লিখে দেবো, 0 শুধু 0 হয়ে যাবে, কোনো অসুবিধা নেই। 0-তে এসছে তো করবে এটাকে। এবার এটাকে এখানে রাখলে তোমারটা, বা তুমি এটাকে এক্সামিনারকে যেহেতু দেখাতে হবে, এটাকে এইভাবে রাখলে, দেখে নাও, ঢাললে তুমি। এবার এই দেখো, আমি কিন্তু এটাকে আউটসাইড করে নেবো, এটা করার পরেই স্ট্যান্ডার্ডে নিলাম। স্ট্যান্ডার্ডটা কিন্তু নিচে লিখতে হবে, রিডিংটা মনে রাখবে, খেয়াল রাখবে। এটাকে নিলাম, এই দেখো করে দিচ্ছি, এদিকে মিক্সিং করে বাই চান্স না মিস্টেক করতে না, সেকেন্ড ওয়ার্ডটা ইউজ করো, এটা থার্ড রড ইউজ করো, এটা সেকেন্ড রড ইউজ করো। তিনটে লেয়ার ইউজ করবে, তাহলে সুবিধা হবে। মানে ভুল করে ওটাতে ঢেলে দিলে তো ব্যাস গেল। এটা রিডিং নেই, দেখো কত আছে, দেখো এটা 27 লেখো, 0.27 লেখো, এটা 0.00 লিখে দাও, ব্যাস 0.00, ঠিক আছে। এটাকে নিলে এই অবস্থা, এই দেখো কিভাবে টাচ করেছি, দেখো এবার টাচ করলে এইদিকে থার্ড ওয়েটা রেখে দিলে এটা এই অবস্থায় রইলো, এটা এই অবস্থায় রইলো, মুছলাম। একটু ভালো করে দিয়ে করে দেবে, করার পরে এবার টিটা দেখবে, দেখো কালারটা নর্মালি এটাতে বেশি আছে, তার মানে 100-র উপরে রিডিং থাকবে। 100 নিচে যদি থাকতো, দেখো ভালো করে, 100 যদি নিচে থাকতো কালারটা তুমি দেখাচ্ছি, নর্মালি দেখো এটা কালারটা দেখতে পাচ্ছ, তা নর্মালি এটা দেখি তুমি বুঝতে পারবে 100-র উপরে না 100-র নিচে, ঠিক আছে। এটা যদি নিচে থাকে তো 100-র নিচে আছে, রিডিংটা 100 ওই হচ্ছে কম আসবে, এখানে দেখো রিডিংটা হচ্ছে বেশি আসবে। এবার তোমরা যদি সবাই মিলে ঠিকঠাক করে করো, তাহলে ওই স্ট্যান্ডার্ডের রিডিংটা কিন্তু ঠিক চলে আসবে। স্ট্যান্ডার্ডটা ফিক্স সবার জন্য থাকবে, কিন্তু স্টেজটা চেঞ্জ করা থাকবে। কারোর দেখে টুকতে যাও না, কেন কি ভাববে না, ভেবো না যে ও ভালো করে করেছে। দেখো দেখতে পেয়েছো 158, দেখো না একটু স্টেবল হতে দাও, রিডিংটা কত আসছে 0.57 খুব একটা ডিফারেন্স হবে না, হয়েছে তো, দেখে দিলে 0.57 স্টেবল আছে, হয়ে গেল। ওই যে 0.5 হলে একটা মাইক্রো ভাবল ছিল, এটা আপ ডাউন করছিল বোধহয় কোনো হবে, তার জন্য এটা হয়েছিল, দেখো স্টেবল 58 এখন পর্যন্ত 575। দিস ইজ দ্য প্রবলেম অফ দ্য ইনস্ট্রুমেন্ট, ইনস্ট্রুমেন্টাল এরার আছে এটা। এই যে সেকেন্ড ডিজিটে ফ্লাকচুয়েট করছে না, 5.78 লেখো, দুটো দিয়ে রিভার্স করে দেখো, খুব বেশি ফাইনাল ডিফারেন্স হবে না। এবার সেকেন্ড ডিজিটে আছে তো, এবার এই তিনটাকে তুমি রেখে দিলে, তোমার এই রিডিংটা দেখলেই তোমার যদি পরে কালারটা চেঞ্জ হয়ে ইকুয়ালও হয়ে যায়, তাতেও কিছু যা আসবে না, কিন্তু হবে না কালারটা। এবারে এটা করলে, করার পর আইডিয়াল নিয়ম হচ্ছে গিয়ে পরের বন্ধুর জন্য এইটাকে ঠিক করে দেওয়া, এটাকে জল দিয়ে ধুয়ে দিলে, আর ও যখন করবে, তুমি যখন টেস্ট করবে, প্রথমেই ও যা করে তুমি ও কিন্তু এই অবস্থা ছেড়ে দিয়ে পালিয়ে যাবে। তোমার কাজ হচ্ছে যে এসে ধোয়া, কোনোদিন বিশ্বাস করে যে বন্ধুটা ঠিক করে পারে, ও করবেই না, ওই করে ওই অবস্থা ছেড়ে দিয়ে চলে যাবে। সুতরাং কালার হবে, হ্যাঁ বন্ধ করে দেবো। That color should be exactly straw color, just like a urine color. And depending if the bilirubin level is high, so this color will be high. If there is bilirubin color is less also, their color will be also whitish, slightly watery appearance. So from that color itself, in the laboratory you can get an idea that what is the degree of bilirubin. But that requires some amount of expertise. So day after tomorrow you give at least 5-6 samples, so that you can see this color change. The bilirubin level will not be exactly the same. It might be same for two individuals, it might be a little bit different, but the absolute color matching may not be there. So what I thought that next time I'll keep this sample and try to do it for the first batch. Similarly for your batch, previous batch samples will be used. So you can see the difference. Say tomorrow I will not be there. Day after tomorrow there will be significant difference between the two. Although the blood sample has been drawn, that I will demonstrate on the last date. Okay. This set we will be doing, and one set I will be doing this thing, the additional points, 2 additional points. Okay. Is this part? So that is the basic purpose of centrifugation. It is hastening the entire process. And clot activator is in because it is normal clotting time, retraction time will be nearly 2 hours time. So this has come down to nearly 30 minutes.
What I used to say, because your answer sheet is the thing which is representing you to the examiner, because you are not there. Okay. As because we are the internals, we know that you are a good student, but although you are not writing, so there is no scope to give the marks. Understood? From next exam onwards, you write whatever asked, to the point, whatever asked. Okay. Okay, yesterday we have discussed about the hip bone. Okay, and today we will talk about the most important bone in our body, that is the femur. Okay. So for Knowing the femur, what is the definition of femur or femora? It's the longest and strongest bone of our body. What is the length of femur? How much? 45 centimeter. So which are the other lengths? So if somebody's height is 6 feet, what would be the height of femur? 1/4. तो कितना होगा height? 1.25, right? 1.5. 1.5. Okay, 1/4 of the height of individual. Okay. Then next one is, which are the other thing? The length is 45 centimeter. Who will tell? Vast difference are? Transverse colon, very good. Are? Tell me other example of 45 centimeter in our human body. Sartorius are thoracic duct, okay, spinal cord, all are 45 centimeter, okay. So first of all, tell me how to determine the site and what is the anatomical position for the femur. So site determination means, tell me, for that we have to know the parts. So what are the different parts? It has got head, globular head, then neck, upper end, shaft and the lower end. So these are the parts, okay. So for site determination, what are the factors you have to know? The head would be directed medially, only medially. How you have to say? Upwards, forward, medially. Okay, UFW, upward, forward, medially, and it is articulating where? With the acetabulum of the hip joint. Yesterday only we have known the acetabulum would be always facing lateral side. Okay, so that's why if suppose this is the which side of femur, so it would be like that, sorry, because symphysis pubis would be forward. Okay, so which side it is? Left side. Okay, left side of femur. So by that way you could determine the side. Okay, and this is the lower end. Lower end would be always facing downwards. Okay, arekta ki trick ache, there is another trick. You have to balance the lower end on the table. Okay, and it would be facing on the same plane because ei duto ki joint toiri kore. These are the condyles. Okay, towards the head this is the medial condyle, towards this one this is the lateral condyle. So it would be facing on the table. Okay, so if you keep this one, you have to balance this one with the index finger. Kon index finger nibe? To the respective hand. Okay, so see, it would be like this. It would be somewhat tilted. Okay, these two ends must touch the table, both ends. Okay, so this is another side determination. Okay, so anatomical position also and side determination you understood. Okay, now one by one part we will discuss. First one is the head. Okay, so head of the femur, about the description what you have to say? It is more than half of a sphere. Okay, so it is about 2/3, write it down, it is about 2/3 of a sphere. This head, it is making 2/3 of the sphere. Okay, and it has got, it would be covered by kon cartilage? Hyaline cartilage. So that is nothing but the articular cartilage of the hip joint. Okay, and the head you are having this border, it would be covered by capsule of the hip joint. Okay, now most important thing in the head you are getting, there is one fovea, small minute, this one pit, it is also known as fovea or pit. The name of the pit is fovea capitis, write it down. This is known as fovea capitis. Okay, capitis কেন বলা হচ্ছে? caput means head. Okay, caput embryoতে কি বলি? caput medusi, ঠিক আছে? caput মানে হচ্ছে head. So here we are having the fovea capitis. Now the question is, tell me the content of fovea capitis. Which are the content? কি কি থাকে এর মধ্যে? At first there is one ligament. Which ligament it is? Ligamentum teres femoris. Write it down. Ligamentum teres femoris. Teres mane ki? Round ligament. Okay, shape would be round. Whereas you will get in our body round ligament. বলেছিলাম আমি এটা তিনটে রাউন্ড লিগামেন্ট আছে ইন আওয়ার বডি কম্পারেটিভ অ্যানাটমি देयर আর 3 লিগামেন্ট রাউন্ড লিগামেন্ট ইন আওয়ার বডি একটা হলো লিগামেন্টাম টেরিস ফিমোরিস which are the other two আর দুটো কি কি একটা হচ্ছে লিগামেন্টাম টেরিস হেপাটিস রাউন্ড লিগামেন্ট অফ লিভার okay ligamentum teres hepatis okay and another one is ligamentum teres uteri uterus e jeta thake so what is the main function of this fovea capitis rather than the round ligament of femur which are the other content আর কি content থাকে any other content so this ligament is providing the pathway for the arteries that will supply the head of the femur okay because this is the last structure okay and it will get the least vascular supply so which are the two arteries that are going write it down there are two artery acetabular দুটোর নামই কি acetabular branch okay because where it is articulating where to the acetabulum okay so acetabular branch of number 1 obturator artery and medial circumflex femoral artery okay so this is about the head of the femur okay next part is the neck so about the neck what you have to say what is the length of the neck so neck is connecting between the head and the shaft right so what is the length of the neck it is about 5 centimeter length is very much important okay the length of the neck is 5 centimeter now it has got how many border how many surfaces very easy two border upper border this one is the lower border this one is the which surface anterior surface this one is the posterior surface now the question is the upper border have articulation of what each and everywhere there is some kind of attachment right so upper border of the neck which structure is attached over here একটু ভেবে বলতে পারবি capsule of hip joint okay capsule of hip joint is attached to the upper border of the neck okay so what is the peculiarity of the capsule of the hip joint is it complete or deficit complete mane it is forming full ring or not it is incomplete okay ki kore anteriorly it is covers the whole area of the neck posteriorly what is happening in this area okay in this area only medial half mane like this area posterior surface divided into this one medial half and lateral half understood medial half is towards the head and lateral half is towards the this trochanter okay so this medial half is intracapsular but this lateral half is deficit understood there is no capsule okay so write it down about the capsule of the hip joint although it covers the whole anterior surface of neck of femur but on the posterior surface only medial half is intracapsular okay so this is about the neck so head you have understood neck next part is What are this type of epiphysis? Femur is the example we are having. How many epiphyses we are getting? 4? কতগুলো example of epiphysis? 3 epiphysis. 3 epiphysis. How? Pressure epiphysis কোনটা? What is the example? This one. Head of the femur. The head of the humerus is the example of pressure epiphysis. Okay. Next one is traction epiphysis. This trochanter. Okay. Humerus e ki hobe? Tubercle. Okay. And this condyle. What about the condyle? Again, it is pressure epiphysis. Okay, this is the pressure epiphysis. So these 3 are the epiphysis. Epiphysis because this femur is an example of typical long bone. Okay, so here in the neck, these are the attachment. Next one is the greater trochanter. Now, if you see the greater trochanter, it has got how many border and how many surfaces? This is the greater trochanter and this one is the lesser trochanter. So in the greater trochanter, how many border are there? Only one border. কোন borderটা দেখতে পাচ্ছিস? Upper border. Upper border. How many surfaces? See, this one is the anterior surface. This one is the lateral surface. This one is the medial surface. Okay, this one is the medial surface. Okay, and this is the posterior surface. Okay, তার মানে কতগুলো বর্ডার পেলাম? একটা বর্ডার, 4টে সারফেস. One border is the upper border. So this is the anterior surface, posterior surface, lateral surface and medial surface. Each and everywhere there is the attachment. Okay, just write it down, very much important. First one is the upper border. It is also known as apex of greater trochanter. It is also known as apex of greater trochanter. So which thing is attached? বুঝতে পেরেছিস কোনটা? কিছু প্রবলেম আছে? So this is the upper border. Okay, upper border or the apex. So which structure is attached? কোন muscle? Piriformis. Like, write it down. First one is piriformis. So now tell me the origin. Piriformis or piriformis. Origin কোথায়? অরিজিন কোথায়? ইনসারশন এখানে। অরিজিন কোথায়? অ্যাকচুয়ালি এটা দেখ পেলভিক ক্যাভিটি, রাইট? পেলভিক ক্যাভিটি। সো ইট ইজ হ্যাভিং, এই সারফেসটা কি স্যাক্রামের? হুইচ সারফেস ইট ইজ? না, যেটা posterior না anterior surface. Anterior surface of the lower third of sacrum have the origin for the piriformis. Okay, and it would be inserted where? To the apex of the greater trochanter. Okay, or the upper border of greater trochanter. Then next one is anterior surface. Write it down, anterior surface. Anterior surface কোনটা? gluteus, gluteus minimus. Okay, gluteus minimus. Insertion of gluteus minimus. Origin কোথায়? Yesterday only studied. Posterior gluteal line আর anterior gluteal line এর মাঝে। ঠিক বললি না ভুল বললি? Anterior gluteal line আর inferior gluteal line এর মাঝে। Okay, exactly কোন জায়গাটায়? এখানে খুব সুন্দরভাবে করাই আছে এটা। ওকে, এটা কি পোস্টেরিয়র গ্লুটিয়াল লাইন? এখানে কি আছে? গ্লুটিয়াস ম্যাক্সিমাস। এই এরিয়াতে কি আছে? গ্লুটিয়াস মিডিয়াস। এটাতে আছে গ্লুটিয়াস মিনিমাস। এটাতে আছে রিফ্লেক্টেড হেড অফ রেকটাস ফিমোরিস। ওকে, সো গ্লুটিয়াস মিনিমাস উড বি ইনসার্টেড ওয়্যার? টু দিস অ্যান্টেরিয়র সারফেস। আর কিছু? bursa of gluteus minimus. Okay, just posterior to the muscle or just inferior to the muscle, there is bursa of gluteus minimus. You all know what is the definition of bursa? It is kind of fibrofatty cushion that will prevent any kind of friction muscle to the bone. Okay, so that is the definition of bursa. So you are having the bursa of the gluteus minimus. Next, what surface is the? A surface ta ki surface? Lateral surface. So lateral surface, which are the thing we will get? This is the lateral surface. Which muscle would be coming here? Lateral ta ki thakbe? So see, there is one thing, this is between the greater trochanter to the lesser trochanter, anteriorly. এই যে লাইনটাকে এটাকে কি বলে? Intertrochantaric line. So above the intertrochantaric line there is a vastus lateralis and below it there is vastus medialis. Okay. So posterior to that, so lateral surface would be also covering this vastus. Okay. Now coming to the medial surface. Medial surface is too much important. Okay. If you see the medial surface, there is one fossa behind the medial surface. This is known as trochanteric fossa. Trochanteric fossa. So which structure is attached over there? Obturator internus na externus? Obturator externus. Okay. Trochanteric fossa, write it down. Trochanteric fossa is for obturator externus. Okay. Now here on the upper surface there is obturator internus along with the superior glamulae and inferior glamulae. Now tell me the origin of this muscle. Which are the origin of muscle? Purpose bole ja, obturator externus. Obturator externus is coming from where? I told you previously that which is the content of obturator foramen, one muscle. কি যায় সেটা? Piriformis. Okay, piriformis ওইভাবে ক্রস করে স্যাক্রাম থেকে obturator foramen দিয়ে ক্রস করে এসে এখানে ইনসার্ট করছে। Okay, what about the obturator externus? Which muscle is present throughout these three part of hip bone? Obturator internus or externus? Internus, obturator internus. Now tell me what is the, here you are having the, inside you are having the obturator internus. Okay, it is a looking like a drop. Okay, it would be attached to above the ilium, ischium pubis hole. Okay, what about the obturator externus then? Obturator externus ta kotha theke ashe? Greater sciatic foramen. Okay. The lower third of greater sciatic foramen, there is the origin of obturator externus. আর এখানে যে lesser sciatic foramen, there is the origin of above কি থাকবে? Superior glamulae, here থাকবে inferior glamulae. Okay, and here is the attachment, this ischial tuberosity. Above that you are having attachment of quadratus femoris. Don't confuse two muscle. Quadriceps femoris কোথায় আছে? Anterior compartment. Here this muscle name is quadratus femoris. Okay. So we are having this medial surface. So write it down. In the medial surface there are four muscles. On trochanteric fossa there is obturator externus, and on the upper border there is obturator internus along with superior and inferior glamulae. Superior and inferior glamulae on the medial surface. Glamulae. So it may vary, okay. There are two kind of English, American English or British English. So it vary. কেউ বলে serratus anterior, কেউ বলে serratus anterior, okay. So it vary. So this is, see, this is the posterior surface. Okay, so posterior surface, if you see between the greater trochanter and the lesser trochanter, there is one crest. This is known as intertrochantaric crest, right? So in the intertrochantaric crest, in between that you could find there is one elevation. This is known as quadrate tubercle. Okay, so just write it down, intertrochantaric crest. It is a crest found between the posterior surface between the greater trochanter and lesser trochanter. Greater trochanter and lesser trochanter. And in between there is one elevated part. There is one elevated part that is known as quadrate tubercle. And that is for insertion of ki muscle bolam? Quadratus femoris. That is the attachment. এখানে একটা পুরো square shape muscle পাবে, that is quadratus femoris, and it is coming from where? From the ischial tuberosity. Okay, পুরো straight আসে muscle টা. Okay, এসে এখানে insert করছে. Okay, then next one we will discuss, that is about the lesser trochanter. So lesser trochanter, what are the muscle we will get? Iliopsoas. Together it is called iliopsoas. Okay, iliacus and psoas major. So tell me the origin of iliacus. The iliac fossa of the ilium. Okay, on this area, this side, interior side or exterior side? Interior side, a side ta. Okay, and another muscle is psoas major. So psoas major is coming from where? কত থেকে কত? লাম্বার ভার্টিব্রা কতগুলো লাম্বার ভার্টিব্রা থাকে? So 2, 3, 4, 5. Okay, so there is psoas major. I told there are 4 posterior abdominal muscle. What are they? Yesterday I discussed 4. Psoas major, then iliacus হবে না, psoas major, diaphragm, psoas major, quadratus lumborum and transversus abdominis. এগুলো কোথায় পাবি? On the vertebra, on the posterior abdominal wall. Okay, so psoas major, one of the muscle of the posterior abdomen. Okay, so this is making the lesser trochanter. Okay, now next write it down, the shaft. So each and everything is important for your viva. Okay, anteriorly ki attached thake, posteriorly ki attached thake, everywhere. Okay, so next one is the shaft of the femur. So shaft is having just the other long bone. It has got 3 border and 3 surfaces. So which are the border we are getting? This is the medial border going to the head. Okay, this is the lateral border. This is the posterior border. How many surfaces? 3 surfaces. Kiki surface? Anterior surface, medial surface, lateral surface. Okay, so one by one we will discuss. At first we will discuss about the posterior border, which is very much important. Okay, so knowing the posterior border, how to determine? It is a continuous line. Okay, so how the line is coming, that you have to know. First one is, this is towards the greater trochanter. There is one elevation. What is this? স্পাইরাল লাইনটা কোন দিকে থাকবে? মিডিয়ালি থাকবে। লেসার ট্রোকেন্টারটা যেটা কন্টিনিউয়াস হচ্ছে সেটা হচ্ছে স্পাইরাল লাইন। ওকে, দেন ফ্রম স্পাইরাল লাইন, দিস ইজ দ্য, হোয়াট ইজ দিস? দিস লংগিটিউডিনাল বর্ডার, অ্যালবা, লিনিয়া অ্যাসপেরা, লিনিয়া অ্যাসপেরা। ওকে, এবং এখানে আরেকটা জিনিস পাওয়া যায় যেটাকে বলছে ক্যালকার ফিমোরালি। What is calcar femorally? The weight of individual would be femur to this thick area, thick surface of this bone. So this is known as calcar femorally. Okay, so in the linea aspera, what are the structure you are having? So first one, see, this is from the medial side. প্রথমে কি নাম আছে? Spiral line. Okay, then the medial lip of linea aspera. Okay, and it would be continuous as, এটাকে কি বলছে? Medial supracondylar line. These are the condyle. So this line, just like humerus, it would be found on the medial side. So medial supracondylar line. Okay, so meanwhile on the lateral aspect you are having greater trochanter. Just below you are having one tuberosity. It is also known as crista glutea. Okay, it is also known as crista glutea. And sometime examiner asked you, tell me about the third trochanter. So this gluteal tuberosity is sometimes considered as third trochanter, and it would be most prominent in case of female. Okay, and it would be found about 20% femora in India. Okay, so এই যে elevated part এটাকে কি বলছে? Third trochanter or the gluteal tuberosity. So which thing is attached over here? Insertion of, দেখ দুটো মাসেল অলরেডি আমরা কভার করে ফেলেছি, একটা হচ্ছে gluteus medius and gluteus minimus, gluteus maximus. So gluteus maximus would be inserted over here, that's why it is known as gluteal tuberosity, and also it is known as crista glutei or the third trochanter. Okay, so from here again one line is continuous, so that is the lateral lip of linea aspera. Okay, and posteriorly you are having another line that is going towards the lateral condyle, so that is known as lateral supracondylar line. Okay, lateral supracondylar line. Now in the posterior border on the linea aspera, how many muscle attachment is there, do you know? As many as 13, 1, 3. Okay, so write one mnemonic. G2, just with alphabets. Okay, G2, P2, A4, 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 V3. Now I would be asking you the muscle, whether you could tell or not. A4, V3, VQ, V3, victory, V3, V3, G2, P2, A4, V3. Okay. Okay, now tell me the muscle. At first G. Okay. First one is gluteus maximus. Another G is gastrocnemius. Okay, gastrocnemius, and this muscle would be found where? This is one of the muscle of our calf. Okay, but which head? Gastrocnemius having two heads, lateral and medial. Write it down. Medial head of gastrocnemius. Write it down. Don't write the mnemonic please on the paper. Okay, so first one is gluteus maximus. Then next one is the medial head of gastrocnemius. Then P2. So first P is, first P, P. You have written B? Pectineus. Now you said pectineus. Tell me about pectineal line. So pectineal line would be found in the hip bone. Yesterday we have seen, right? Pectineus, pecten pubis. Also it is found in the femur. So which is pectineal line? This is the spiral line. Okay, and one is this is the gluteal tuberosity, lateral lip, right? So in between one line is going, in between. Okay, so that is known as pectineal line. Okay, so there is insertion of the pectineus. So first P is pectineus. Okay, next one is add a P key. Only we are concerned about the linea aspera. Plantaris. Next muscle is the plantaris. কেন হবে? এটা lateral supracondylar line এ থাকে. Okay, lateral supracondylar line এ থাকে. So this is the next muscle. Then A4, right? A4, you know there are three adductors. Adductor longus, adductor brevis, adductor magnus. Okay, laterally, medially and most medially. Most medially কে থাকবে? Adductor magnus. Okay. Adductor longus কোন সাইডে থাকবে? It's one of the boundary of femoral triangle. তাহলে কোন সাইডে থাকবে? Lateral সাইডে থাকবে. Adductor brevis আর magnus medial সাইডে থাকবে. Okay, because these are all are the muscle of the medial compartment. Okay. Then next one is A4. A4 কি করে হলো? সত্যি তো? Articularis genu. Small minute muscle. Articularis genu. And this is found, this is the small minute muscle The part of the muscle, this is actually the part of the adductor magnus. Okay. This area. Articular is genu. Okay. Then the phi3, you know, there are three vasti: vastus medialis, vastus intermedius, vastus lateralis. So as many as 13 muscle, okay, on the linea aspera, right? So now coming to the posterior border is over. What about the medial border? Medial border, which thing is attached? Vastus intermedius. Okay, because vastus medialis would be superior to the vastus intermedius, and to the lateral border there is vastus lateralis. Okay, this side, because it is making what? The anterior compartment muscle. So all three muscle you are having this area, quadriceps femoris. Okay, this side would be vastus medialis, vastus intermedius, this side vastus lateralis, and superiorly kon muscle ta asse? That is the rectus femoris. Rectus femoris. Okay. So what are the other muscle you will get on this border? There are two borders. This is the medial side. So this is medial supracondylar line. This one is the lateral supracondylar line. So in between that there is formation of one triangle. So it is also known as popliteal fossa. And what is the content of popliteal fossa? The popliteal muscle. Because this muscle is looking like a diamond. Some of the part on the femur, but some of the part on the tibia. Okay, next part, write it down, the lower end. Okay, next one is the lower end. Okay, so on the lower end, it is having how many condyles? The medial and the lateral condyle, right? And in between that, there is one crest, okay, or fossa. It is known as intercondylar fossa. And this condyle having two surfaces. Ki surface ache? Patellar surface mane only this anterior surface. It is also known as anterior surface. And posterior, this surface is known as tibial surface or the inferior surface. Okay. Knee joint patellator, just here it would be articulated, and this condyle will articulate with the condyle of the tibia. Okay. In between that, there is a meniscus. So it is forming the knee joint. Okay, tell me what is the mechanism of flexing and extending the knee? Do you know? What is the mechanism? What is the position of bone? You close kor do na. Mechanism ta ki ache bol? Knee jointer mechanism. Suppose now all of you are sitting, right? So what is now? How is the position of the bone? Locking এর opposite কি? Unlocking. I have asked what is the position of bone. এখন কিভাবে আছে বোনটা?